who, without needing words, teach the world what it is to love and fight. That's the clan we belong to, the Heart Warriors. Primary step in understanding and conquering CHD is raising awareness among public about the importance of early diagnosis of congenital heart defects and its associated treatments. On considering the birth prevalence of congenital heart disease is 9 per 1,000, and the estimated number of children born with congenital heart disease in India is more than 2 lakhs per year. This shocking figures is more than enough to explain the importance of having a well-established support group for congenital heart patients and their beloved ones. CHDPM, Congenital Heart Defect Protective Mission, keeps a strong vision towards ensuring a life with dignity for all who are born with congenital heart defects. Without much delay, let me enter into the duty that is vested on me. A warm and pleasant morning to one and all present here. It's my immense pleasure to welcome such great personalities to the webinar, Congenital Heart Defects, Issues, Concerns, and Solutions. First of all, I would like to welcome Dr. G.S. Sunil, Senior Consultant at Department of Pediatric Cardiac Surgery, Lisi Hospital, Ernakulam. With all due respect, we welcome you to this meeting, sir. Next, I would like to welcome Dr. Maniram Krishna, Consultant Pediatric and Fetal Cardiologist, Tiny Hearts Pediatric and Fetal Cardiac Center, RK Hospital, Tanjavur. With all due respect, we welcome you to this meeting, sir. Now, let me welcome Dr. Navneeta Shashikumar, Clinical Associate Professor at Department of Pediatric Cardiology, Amrita Institute of Medical Sciences, Kochi. With all due respect, we welcome you to this meeting, ma'am. Next, I would like to welcome Dr. Srihari M, State Nodal Officer of Child Health and RBSK, National Health Mission, Thiruvananthapuram. With all due respect, we welcome you to this meeting, sir. Now, let me welcome Dr. Smita Mishra, Senior Consultant at Department of Pediatric Cardiology, Manipal Hospital. With all due respect, we welcome you to this meeting, ma'am. Now, let me welcome Dr. Mahesh Kapanail, Professor at Department of Pediatric Cardiology and Head of 3D Printing Anatomical Laboratory and AR and VR Visualization Laboratory at Amrita Institute of Medical Sciences, Kochi. With all due respect, we welcome you to this meeting, sir. Next, I would like to welcome the bold voices of our CHD parents community, Ms. Tarana A. Tabassum, Ms. Srishti Grihotra Reddy, and Mr. Amod K. Kushwa. A warm welcome to all of you. Now, I would like to welcome Mr. Rajdeep Singh as a common yet powerful voice of adult CHD community. We also draw motivations from our mentors and advisory board members who are with us from the beginning of CHDPM. We would love to welcome all our members and advisory board members to this webinar. Finally, with all due respect and love, we welcome all who are here to watch CHDPM's first webinar session from all around the globe. A warm welcome to one and all present here. Now it's time to leave from my duty. Let's join hands to make the world a friendly and safe place for all CHDs. Thank you all and have a fabulous day.
Thank you so much. Thank you so much, Hari. That was a beautiful way you welcomed everyone. I'm sure everyone feels welcomed as well. And I can see Dr. Raj Shekhar over there, and I cannot move forward without welcoming him personally. Thank you so much, sir. You have been a mentor and a real support for each and every endeavor that we are taking. You are there, we know you are there, and we are so happy to have you. Right. Now, going forward, let me what do I say? Sunil sir, he is like our doctor buddy, right? So Dr. Sunil GS, Senior Cardiac Surgeon, Pediatric Cardiology Surgery, Lisi Hospital, Ernakulam, is our mentor and guardian. A life dedicated to the service of the CHDs. That is what would describe him perfectly. May I call upon Dr. Sunil for the presidential address. Sunil sir.
Yeah. You can see?
Yes, sir. Yes, sir.
Sir, you
So-
are audible and video.
Yeah, I'm starting. So I'm beginning my talk, as the title suggests, it is the discussion about congenital heart disease, issues, concerns, and solution. As already mentioned by Dr. Hari Krishnan, this is based on Dr. Anita Saksena's paper published in 2018. There are estimated 2 lakh births in India per year. I mean, around 2 lakhs children are born with heart disease in India, considering about 0.8 to 1% incidence of heart disease per 1,000 population. Of these, about 20 to 40,000 need surgery in the or intervention in the first year of life. You can hear me?
Yes, sir. Yes, sir. Please continue.
Yeah. Of these, about 10 to 20,000 may need intervention per year in India. I mean, what I mentioned was around 20 to 40,000 need surgery or intervention. Only the facility to do only half these patients at the moment. So what happens to the untreated patients? So some of these children with correctable lesions in the appropriate age that can lead to normal life, they were not operated, and after some time they become inoperable, and they have to lead a lesser quality of life the rest of their life. But there are other complex heart surgeries. Without surgery, they won't live beyond 1 year. But there has been tremendous improvement in the surgical outcome in the last 2 to 3 decades. Since more and more children are having surgeries and they are becoming adults, there are more adults in the population than children with heart disease. So if you group these adults with heart disease, they can be included in 3 groups. Group 1, this actually comprises about 50 to 60% of the population. They are actually simple correctable lesions who had a completed treatment in the appropriate age, like ASD, VSD, PDA. As I mentioned, they constitute the largest number. They have more or less normal lifespan. They don't really need a serious recognition as patients with the treated CHD. But in the group 2, these are the people with the 2 functioning ventricles. So they can have corrective surgery, but the only problem is that they need re-interventions. Some of them had valve repairs or replacement or conduit placements. They have to reoperate it as and when needed. Managing them at the proper time is important. Otherwise, they develop this damage to the heart, and delayed intervention will not produce appropriate results. So key here is that correct follow-up and appropriate intervention. In that case, they can lead a more or less a normal lifespan. They will have a more normal lifespan. So coming to the group 3, these are the people having complex heart disease. So mostly the single ventricle patients come in this category. As I tell these relatives, if one chamber is not there, you cannot create another chamber. So what we can do is do some adjustments in the circulation so that they can lead a more or less normal life. So they may or may not require further surgery, but some of them eventually end up in heart or heart-lung transplantation. So all these patients, all the patients who had single ventricle or who are having a ventricular dysfunction will come in this category. So coming to the natural history of treated and untreated heart diseases, there are conditions, as I mentioned, once they operate, they have a normal lifespan and they are like normal population. And there are conditions with the only marginal benefit of surgery, actually, because if you operate, they will have marginal benefit. And of these people also, you need a constant follow-up and corrective intervention. Otherwise, it is better leave them alone in the first place and do a medical management. But as the experience with managing some of this condition is evolving, and some surgeons are attempting these procedures. So for example, to say a condition called pulmonary atresia, and when there is no pulmonary flow that is coming from the heart to the lungs, and this pulmonary flow is made up of small vessels coming from the aorta. So you defocalize them and complete repair. Some of them constantly require a follow-up and they need a intervention. Otherwise, they will become worse. For them, for these patients, leaving them alone will be better than treating. So what is the extent of the problem in India? In India, how many adults are there with the heart disease, treated or untreated? Exact number is not known. An article published in Circulation in 2010 says in United States, there are 2.4 million people with heart disease living in United States. Of these, only 1 million are below 18 years and 1.4 million above 18 years. So that means more adults are there than children with heart disease. Of these, about 3 lakh people are estimated to be having severe heart disease. So comparing the population of United States and India, there can be up to 1 crore Indians maybe having treated or untreated heart disease. So this, as I mentioned earlier, this group 2 and group 3 patients with complex heart disease, they are the people who have to focus on, like adult congenital heart disease. So this prevalence of adult CHD is increasing. Now, like the previous study, there are more people with the CHD beyond 18 years there than under 18 years. So they have been managed in special clinics, and various terminologies are used to describe them, like a grown-up congenital heart disease, GUCH, or adult with congenital heart disease, ACCH. So whatever is the terminology, young people and adults with CHD need a lifelong expert medical care, especially for those patients with residual lesions and who are only palliated. If we come to the actual problem with living with heart disease, they will have this varying degree of effort intolerance. These children in the schools, they will realize that they may not be able to walk fast like their colleagues or classmates, and their exercise tolerance is limited, and they should have that understanding and about their limitations, and then they can lead a reasonably better quality of life. Otherwise, they will be frustrated. And some of these patients can develop rhythm disturbances. So suddenly this rhythm disturbances occurs. A previously asymptomatic person can become suddenly symptomatic. They need interventions like electrophysiological studies and many things. And of course, they can develop heart block and the need for a pacemaker. That once a pacemaker is in, pacemaker change and interrogation is needed. And these people can develop valve leaks, ventricular dysfunction, and as I mentioned earlier, unless there is some kind of a lifestyle adaptation is there, they do the high physical activities, these valve leak and ventricular dysfunction is going to increase. And of course, there are various complications following Fontaine operation. Their cardiac output cannot go beyond certain level, and their exercise tolerance is very low. And of course, the need for intervention is there. And this adult with congenital heart diseases, they have non-cardiac issues like infection, like COVID. And many of these patients who had undergone surgery developed COVID, and they require more attention and treatment. And these people can develop acquired heart diseases like coronary artery disease. And all these things require multidisciplinary management. And coming to the social issues, actually, growing up with congenital heart disease is something only the feeling can be shared by the parents or the patients itself. How when they become aware of the heart disease for the first time, maybe by seeing that scar, visible surgical scar, and these children will ask why I am having this scar here. And when they are frequently, they have to go to the hospitals and they have to take leave from the school, and they were worried actually. So at that time, we will have to counsel them in stages so that they won't get frustrated. Actually, all these counseling and all are important. And regarding the education of these persons with heart disease, the 20% of the patients may be having a attention deficit disorder and neurological problem, but majority 80% have got normal intelligence. In fact, some of these patients having a normal sibling, the parents will tell that there is no difference. This boy will study better than the other boy. So the intelligence wise, there may not be much problem. Only the physical activity may be restricted to certain level. And the question whether they need such people, whether they need special schools, probably no need actually, because they probably won't be able to participate in this competitive sports, and the physical activity, they have to do less activity. I mean, that will help in the long run. There is no studies associated to prove this, but logically thinking, a person with having a ventricular dysfunction or a valve leak, it's tend to increase with the physical activity. And the teachers and the school authorities should be aware of this, their children's problem. And some of them, the school, it will be in the second story or third story. So these children has to climb stairs. And some of the schools will have very heavy school bag and all. All these things are small problem associated with the congenital heart disease, and these relatives will come and tell us. And regarding the rehabilitation of these people, employment, finding a suitable job is very important. As I mentioned earlier, 80% of them will have normal intelligence, and most of them have got normal intelligence. They study well. They may not be able to do very strenuous activity. It also depends on this condition, their underlying pathology. But by and large, they may not be able to do a physical activity like a normal person, a person with a normal heart. And but nowadays this IT field and all are coming up, so they can find employment in IT fields and many areas where there is not much strenuous activity. So they have to, at the end of the day, they have to acquire ability to stand on their own. And the social system in India, unfortunately, it is like a family oriented. When the parents become old, children are supposed to look after them. Actually, unfortunate aspect here is that when the parents become old, the children also, these persons with heart disease also will become reach the end of their natural history. So a strong social support is needed in such situation. A person with heart disease having a normal siblings without any problem is a good solution in this. But you know, some of these parents opt only when they have heart disease patient, they don't opt for other children because their focus, they wanted to be into this only child. So that is also a important factor. And regarding rehabilitation, coming to marriage, most of the patients can undergo marriage. Problem in India is majority of the marriages are arranged marriages only. Majority, maybe 95% or more than that. So finding a partner may be difficult because there is social stigma associated with the heart disease. So finding a partner may be very difficult. This is something very important factor. And some regarding problems with the pregnancy and childbirth, some patients cannot conceive actually. This has to be counseled before marriage. Some people can take, or you can tell them you have to take risk, like there can be IUGR or abortion and all these things. And there has to be adequate counseling during pregnancy and childbirth. Of course, a spontan person patient coming for delivery should be in a very in an institution where you have expertise in managing CHD. And one thing about disability, there is a government of India issues a disability certificate. Actually, that will help in the finding jobs, and there will be scholarships, and even for writing exam you will get more time. And various conditions are included in the 2016 Act. In fact, they have added many things from the previous Act. Congenital heart disease doesn't come into this picture at all. It is something we can seriously discuss and take necessary steps so that this CHD can be included in the this Disability Act, and they can have this disability card, and with this card they can have some financial concessions, job reservations, many things are possible. And financial problem, actually that is important problem. Only a small percentage of the patients can have that ability to finance their the treatment. Majority of them depends on other sources. There are various government schemes available. Kerala has got efficient Hridayam scheme. They have incorporated some all the private hospitals who do congenital heart surgery also, and provide free treatment for up to 18 years, irrespective of their financial status. That free treatment is given. It is efficiently run scheme. But beyond 18 years, there is no scheme, such scheme available, or maybe it's not viable schemes available. So insurance, regarding insurance, some of the foreign companies or some of the people who works in high IT firms, they have insurance that will cover the congenital heart disease also. But the general insurance that is available to the public, they don't cover the congenital heart disease. This is some area we have to look into seriously and take the necessary steps. And what is the future holding for us? So we will have to have enough personnel to manage the ongoing problem. So in the future, there will be a large number of treated people with the congenital heart disease who requires admission. There can be admission every day with some problem. So there has to be enough hospital beds and necessary infrastructure. Human resources is important. We should have enough surgeons, cardiologists, anesthetists, nurses, and associated paramedical staff to manage this. And similarly, as I mentioned, these people having other diseases, they also to be treated in a very center where you have the expertise available. So what our goals, what we can suggest to the government is that only is that we don't know the extent of the problem. We just derive these numbers from other sources. So we can ask them to create a national database for persons with the CHD, or CHD can be included in the next census. And as I mentioned earlier, disability, CHD can be included in the disability. And of course, with the disability card, you can have this reservation in jobs and some financial support. And there has to be facility to provide guidance in pregnancy and childbirth, and financial supports. Government schemes should come, and inclusion in insurance. To conclude, there has been increase in adult CHD. It is going to increase only because of this improvement in surgical techniques and outcome. And disease heterogeneity also improving. Previously, the conditions we don't operate. Nowadays, we are operating. So they are also coming into the picture. And surgical work or interventions will get more complicated. So you do catheterization, a person who had undergone several catheterization previously, the getting access and all will be difficult. So need more people with the expertise, and the resources is important, and need to have more people in our field. Another thing, educating some of the patients, they can give guidance to a particular group of patients. And it is important to have public awareness, media coverage, and to achieve some of our goals. I think I will conclude my session here. Thank you very much.
Thank you so much, sir. That was such an exhaustive kind of information that you shared with us. Most of the questions and concerns that our parents had put in the survey form, I am sure that those concerns got addressed through the presentation. But then the questions always remain, like being a CHD, it's not easy. And as just now we saw, there are so many things like till 18 years, this RBSK project is there, but not all the states in India is still following that. Only very few states, and there are like remote villages where there are so many people who do not know about any of these schemes or facilities. They do not get the kind of medical attention or the medical care. And we also have this ASHA workers and all. I mean, we should train them. We should train them so that they at least get to identify. And we are talking about 5G and all. There should be a proper networking system wherein hospitals are connected, and any such incident has to be reported then and there. Because a chance is a chance at life, right? Every person deserves that. We have seen how people were running around during COVID times to save lives. CHD lives also matter, right? So we really need, and 18 is not an age where you like save a person's life, and at 18 years you just drop the person and think, okay, they'll manage on their own. The society has got, I guess, some kind of a responsibility to every person in the community, and it's really sad that there are so many problems, but the solutions don't seem to be happening any time near. But to know more about this, we really need to hear the stories, the real stories of parents who have gone through this journey, so that we get to know what people go through when they have a child with CHD. The whole life actually turns around, like all the aspirations, all the things, that expectations that we have when we have a kid. Everything just, people feel like we have been dropped into a well. There is no support, nothing at all. Thank you so much, Sunil sir. Now let us move on to another person, and we are going to hear a story now. It's not a story, it's a real life story. Like I would say, some journeys are more complicated than others. The journey of a CHD parent is a steep uphill climb with no time to rest. I'd like to call upon Mr. Amod K. Kushwaha, who is a member of our CHDPM family, to hear about his journey as a CHD parent. Amod sir, please.
Thank you, ma'am. Thank you so much. First of all, I extend my hearty regards to the dignitaries of the medical field present here, Dr. Rajshekhar sir, Dr. Sunil G.S. sir, Dr. S. Maniram Krishna sir, Dr. Navneeta Sasikumar ma'am, Dr. Sri Hari M sir, Dr. Smita Mishra, and Dr. Mahesh Kapanail sir. And also I extend my regards and welcome to the members of the CHD community like Hari Krishnan, Rajdeep, and Apu, who are the CHD warriors, and parent members from the CHDPM, it is Jonali ma'am, Srishti ma'am, Sajni ma'am, and Tarana ma'am, all this. In fact, as you told, this is not a story, it is actually a journey that I have been moving on since last 7 years. And I remember the year was 2015 and the date was 7 February. My son Parth was born at 9 p.m. And suddenly I noticed that his lips are turning blue, his nose tip is turning blue, and his fingertips is turning blue. I reported the matter to doctor, and doctor put him simply into that incubator. So he spent there whole night. Next morning he came out, and he spent with us that day and night. But again next morning he started turning blue. Then again he was put into that machine again, and this time for 3 days with the regular medications and cannula, all that that medical systems applied there. And within next 3 days, his cyanosis, that is the blueness, subsequently that reduced, and he was discharged after 2 days. While discharging, the pediatrician that used to come there to visit my son, he said, "You must go for echo test for your son." And I was surprised. Actually, I heard this term for the first time. But at that time, when I took my son to home, and there was a swine flu infection on the surge, so we decided only after 1 month to take my son for that medical checkup to a pediatrician, and we went to Agra, and we met one doctor there. Doctor sent us to another doctor for echo. So the doctor who performed the echo, he called me in his chamber and he asked me, did you have his fetal echo done? I said, no, I didn't. He said, you should have done the fetal echo. And then he explained everything, that my son is having CHD, and he also told that there are very, very less chances of survival also. It was like a bolt from sky, and I could not understand what to do at this moment. So simply I went back to the pediatrician whom I have met. He just saw the report, echo report, and I remember his lines. He said, you immediately go to AIMS if you want to see your son alive. And AIMS was a place that was totally unknown to me for that time. And the time when doctor was saying these things to me was around 10 p.m. night. And next morning we left for AIMS. And when we reached AIMS, we could not understand what to do, where to go for the medical aid, and which person to contact. Actually, everything was unknown to me. I went to emergency. I took my son to emergency. The doctors there said that we don't have any bed, so we cannot take your son for now. So I was disappointed. I was depressed also. I felt anger also about the healthcare system of the country. But then one doctor, he suggested me to come through the OPD. Then I said, okay, fine, I'll come through OPD. But when I went to OPD, I found that there were some 200 parents were there roaming here and there. All were trying for the son OPD card for their wards. And one surprising thing I came to know that only 30 patients could be registered in a day. So it was a Herculean task for me to get that OPD card for my son. And you'll be surprised to know that people started lining up for getting that OPD card from the night 12 a.m. only. And the month was March. It was quite cold also. Anyways, I struggled hard and I got the OPD card next morning. And we met Dr. Anita Saxena, ma'am. And he suggested for echo. After 1 week, echo was done and everything was clear. And then ma'am actually explained the nature of CHD my son has. Actually, it was a critical type, and she told me that your son is having that tricuspid atresia, pulmonary stenosis. Your son is having VSD. Your son is having hypoplast ventricle also. That means your son is having that single ventricle, his ventricle is not developed completely, and told me that 3 surgeries would be performed, but then also the life expectancy would be very, very less, say 20, 25 years or little more like that. And my case was referred to Dr. Rajsekhar sir. I went to Dr. Rajsekhar sir and he explained once again everything to me and asked me to decide whether I would like to go for surgery or not. I simply said, sir, I would go for surgery. And then this journey began. And my son has undergone the BT shunt surgery in 2015. And then he underwent that BD Glenn surgery in 2017. And then recently in 2021, he underwent his content surgery in the month of October 2021. And all the surgeries were performed by Rajsekhar sir only. And with God's grace, my son is now fine. He's playing with his younger brother. He is smiling with us. He is fine. I can say that today is fine. So this is a journey. And many questions are there, as Sanjay ma'am also told that one question frequently strikes mind: why me? Why my son? But when I sit back and look back, and I discuss with other parents, because when I go to AIMS, I try to discuss with other parents, try to find their concerns, try to find their worries also. And one thing I found very common, that all the parents, they face a lot of hardship in this journey. They really face a lot of hardship in their journey. And some of the journeys that I have noted are actually common to all of us, that can be categorized into the 3 heads. There are 3 heads of the hardships that all the parents who come to know that his ward is having a CHD problem, they face. The first is the healthcare infrastructure in our country. I mean, the condition is really very pitiful, and there is disproportionate ratio between the pediatric cardiologists, pediatric cardiac surgeons, and the number of CHD cases. As Sunil sir also told that roughly 2 lakh to 2,40,000 CHD cases are coming up everywhere in our country. So, and the pediatric cardiologists and pediatric surgeons, they are really very, very less. So there is a type of disproportionation. This is a big problem. And the problem especially worsens when you reach the places like smaller cities. They are not having any proper cardiac care center, and whatever cardiac care centers are also there, they are in big cities like Delhi and Bangalore. So there is a type of maldistribution, there is improper distribution, and that means the population of a particular city is able to access that particular healthcare service, and the population of other cities, they are not able to access that. So again, the discrimination starts from here only. I mean, there are many parents who are not getting proper treatment, who are not able to find access to the healthcare. So this is one thing, one problem which is faced by most of the parents, and this is most common thing, that is a problem of the healthcare infrastructure in our country. Second problem is the cost associated with the treatment of the CHD, and also the associated financial burden that incurs on the parents. Uh, if we see, mostly except few government hospitals like AIMS Delhi, PGI Chandigarh, and Jipmer Pondicherry, and Jayadeo Hospital Bangalore, UN Mehta Hospital Ahmedabad, and Nizam Institute of Medical Sciences Hyderabad, and some of the hospitals of charitable trusts. The surgeries are being carried out in the private hospitals, and the cost is so high that it really becomes unaffordable for a larger section of Indian population. And when you talk of the government institutions also, they are actually overburdened. I have seen the case of that AIMS. The caseload is so high that we encounter a large waiting list. Various reasons can be there. Mainly, there is lack of adequate staff, there is lack of resources, there is lack of supply, and this increases the waiting period for the surgery. I mean, many parents are waiting for the surgery. So this worsens the situation, and this actually pushes the parents into the depression, into the state of deep depression. And I have seen many cases where the parents belonging to poor socioeconomic conditions, they have lost their jobs also for getting just their wards to get operated at a place which is far away from their native places. So they have to move to distant places. This is another problem. And the third problem that parents share with me is that stigmatization of that CHD. As Sunil sir also shared that there is a good perception about the CHD in our society. A person who is having a society, who is having a CHD is not regarded good for anything in society. The perception is like that, and in that also there is gender bias, because if if a male child is getting a CHD, he is getting proper attention. But if a female child is getting CHD, it is quite possible that the female child is not getting that proper type of attention. She is not getting proper medical care also. And even if she is getting treated in time, there are problems associated with her marriage and all like that. So these are the social problems that the parents are facing and parents have shared. Along with that, the parents shared certain concerns also, uh, which frequently worries them day and night. These concerns may be of general nature, like the general care and medical care of their CHDs. We know that for our wards, for our sons and daughters, we are frequently seeing the conditions of low saturation and associated respiratory problems. And along with that, we encounter the associated physical and mental health problems of the CHD cases and other associated problems. For example, if you talk of my son, along with the CHD, he is having some hearing problem also, that is also getting treated from IMSS only. And the most important thing that bothers and that worries the parents is the life expectancy of these CHDs. Every day and night we are thinking, what would happen tomorrow? What will happen tomorrow? So this thing really worries we as the parents. Another thing is the financial and social security of the CHD kids, CHD warriors, because the companies are not giving any type of insurance, and the doors for the jobs in the public sector undertakings and that private sector are already closed. These kids are suffering a lot of losses in their studies also, because of the frequent visit to the hospitals for medical checkup and that surgical intervention. So this is another problem. And even if there are certain persons with CHD who are in job and they have to take a significant number of days of leave, they are losing their jobs frequently. This is also being encountered. So these are some of the problems. These are some of the concerns. One thing that I specifically noted by moving here and there, one problem is also the rampant corruption and bribery in the government setups. I mean, bribery may not be necessarily in the form of money only, that may be in form of political favoritism also, that may be in form of political approach also. Suppose you have got the date of surgery or some test, and some other person comes from some political background, having some political backup, and your bed is given to that person. So this also deteriorates the condition of these people. And in these cases particularly, the persons from the underprivileged sections, they suffer the most. So this must be taken care of. We as a parents, we would like, we desire some changes in the existing system, and uh, some of the changes can be, we can establish the better CHD care infrastructure in the government sector. In fact, all the hospitals in the government sector should have the CHD care center, and dedicated CHD care center should be established on the basis of that population criteria in different states. For example, I belong to Uttar Pradesh. It is a big state, and so we need more number of CHD care centers. And we can say that CHD care infrastructure should be established in all states, particularly in the smaller places, smaller cities, and depending on that population criteria. And we must consider, I mean, not only we, actually the company should consider, and the policy should be framed that these people must get some form of health insurance coverage, so that at least life goes a little smoother. And free lifelong medical care should be, for that I was thinking that some unique ID cards may be generated. Sorry.
Let us give him a minute. I guess he went to fetch some water or something. Let's just wait for him for a couple of minutes.
Yes. Okay, ma'am, you can continue.
Okay, sir. Yeah. Okay. Is Amotsa going to come back? Did he say that? I mean, I didn't quite catch what he said.
Okay, ma'am. Okay, ma'am. I'm sorry.
Yeah.
Actually, I had
it's
some problem.
perfectly all right. I mean, you're continuing, right, sir?
No, I'll continue. Actually, there was some problem with my throat. I have throat infection for last two days. Okay, so these are the things that changes we desire. Some ID cards may be generated, and these ID cards may work like okay. So these ID cards can be used as the cashless health cards also. So these provisions can be there, and most important thing is there must be some certainty of jobs in the public sector. I mean, certain posts must be earmarked, and above that, CHD awareness campaigns must be run across the country. And the parents must be informed that some of the CHDs are totally curable, and in these things we should not feel the hesitation or kind of shame in discussing these things with the parents. Okay, so we should run the destigmatization campaigns like that. So this is my story. The world is beautiful, but we should make the world more beautiful for our CHD warriors also. Okay, this is the story of every single parent who's having a CHD kid, and at least we must help these warriors realize their full potential. Okay, so I should wind up myself. Thank you so much.
Thank you so much, Amod sir. Actually, the story he shared might have so many things in common with most of the parents who have got a CHD kid. Now, before going forward, I have to mention a name, because without that, it would seem like I'm not doing justice to the person. There was this mom from a remote village in Kerala who sent a letter to the president, APJ Abdul Kalam, who was the president at that time. I mean, it was like she had read in a newspaper that a Pakistani kid was getting free medical care from Narayana Hridayalaya. And the letter actually said, okay, if a Pakistani kid could actually get this kind of an aid, why can't my Indian son get the same thing? I'm not that rich. I cannot afford the surgery costs and all. I come from that kind of a family. So how come I'm not entitled to it? And you wouldn't believe, but a check of, I had submitted, that mom is me actually. I had submitted the letter and it was written in the last page of my physics record. Right. And I sent that, and along with that, I sent the papers. And you see, APJ Abdul Kalam, the president of India, he just took times to respond to it. That is the biggest thing that happened. And 25,000 rupees check was straight up given to Narayana Hridayalaya. That is how the system has to work. And here we people are all breaking our head and doing everything possible, and our voice is not heard at all. Here, just one letter from a mom in some remote place reaches the president, and there is at least some solution to it. I wish every political figure who just takes up this position to serve the nation, they do something about this, because we really are in need. We need, as Amod sir said, we really need better hospitals. Doctors are overburdened. They need a little bit of relaxation, but more doctors, more hospitals, more infrastructures, more money has to be pushed into the health sector. There is no other way this is going to have a solution. And from there, let me just move on to the thing. Everything has a beginning, right? So as we say, a stitch in time saves 9, and an early detection of the defect would have stopped the storm right at our doorsteps. May I now request Dr. S. Maniram Krishna, consultant pediatric and fetal cardiologist, Tiny Hearts Pediatric and Fetal Clinic, RK Hospital, Tanjore, to walk us through the intricacies of fetal echocardiography and genetics of the congenital heart disease. Maniram, sir, please.
Thank you, Sajani, Apu, and Hari, for giving me the opportunity to talk in this forum. Can you please make me a co-host for me to share the screen?
Sure, sir. Apu, please. Mangla, you could also help, ma.
No, I cannot make him. I'm just trying. I'm not able to make. I don't have that option.
Okay, then maybe Sindhu. Yeah.
Sindhu, please make. Yeah. Oh,
yeah.
Okay. Right.
Thank you. Can you see my screen?
Yeah.
Yes, sir.
Yes, sir.
So I'm going to talk about the importance of fetal echocardiography and genetics in congenital heart disease. It's going to be a very short talk, and I promise you there will be not much of technical terms involved in this talk. There will be only 2 slides on technical terms, nothing more. Now, whenever, as a layperson, we hear of heart disease, our perception is, either a very old person, our grandfather, or one of our great uncles or aunts with some chest pain who gets admitted in the hospital, as a procedure, bypass surgery, and all that. Or because Valentine's Day is coming soon, we might be thinking of young people with heartbreaks. So that is what we think of as far as heart diseases is concerned. But now heart disease can occur in children as well. And these heart diseases, as Sunil sir explained and as Amol also explained, can be of very different types. So there can be holes in the heart. There can be a chamber in the heart which is not at all formed. There might be a valve which does not either open properly or close properly, or some of the big blood vessels in the heart may not be arising from where they should come. So something which should come in the right side may come from the left side, and vice versa. So these are what we call structural heart diseases. And these heart diseases are more common in children rather than the other types which we associate with adults. So why are we worried about CHD so much? The reason is, if any pregnant mother who has met an obstetrician would have heard about Down syndrome, about the importance of screening for Down syndrome, because it can be found in the, in early pregnancy itself. So that is not every obstetrician talks about the importance of Down syndrome to every prospective mother. And the incidence of Down syndrome is 1 in 700. And even though we can do a lot of things to improve the quality of life of children with Down syndrome, there is no cure for the syndrome per se. Then there are some diseases which get a lot of importance. One such thing is neural tube defects. So neural tube defects is where part of the head or part of the spine is not formed at all. The back or the head is not formed at all. It's one of the it is one of the most severe congenital anomalies with an incidence of around 1 in 1,000. And the most common forms of these neural tube defects are actually incompatible with life. So there's no way a child with this defect can survive after birth. Yesterday, I attended a seminar in our local pediatric forum on diabetes in children. And there was a huge attendance, like almost the entire pediatric community had turned up for this seminar for a disease which has an incidence of around 1 in 6,000 or 1 in 10,000. And even with proper care, the quality of life may not be perfect in all these children. And finally, we come to congenital heart disease, which have an incidence of 1%, that is 1 in 100. And unlike most of these diseases, as Sunil sir mentioned, the commonest ones can be completely cured. You need not even follow them regularly. Once they have their surgery, they can lead a completely normal life. And even in the uncommon ones, with palliative procedures, yes, they may need repeated procedures, but they generally have very good or excellent quality of life in almost all the types of congenital heart disease. So we have a common problem, and we have a problem for which good solutions are available. And if you take a more focused subset called critical CHD, so this is approximately 1 in 3 of all CHDs. And these are diseases which, if we don't identify and treat them in the correct time frame, like Amol's child, they can result in either death or very significant disability. And that is why we are talking about these challenges. So what are the challenges facing these parents with CHD? Some of them have already, Amol, from a first person experience, has already told us about quite a few of these problems. The first is lack of awareness about management options. The second is, even though we have facilities all over the country, they are still few for our population, and families have to travel a really long distance. The third, again, is the cost involved in the management. And the fourth is social stigma associated with heart diseases. Now, if you take the first three problems, they can be overcome if we have adequate time to understand and explain the problem to the parents. And with critical CHD, the major problem is you may not have time to overcome these challenges because you need to treat the baby as soon as possible, which is where I believe Fit Lecocardiogram has a role to play. So what is a Fit Lecocardiogram? So this is a scan which is performed during pregnancy, which can look at the heart and diagnose almost all of these critical congenital heart disease. So it is best performed at 5 months of pregnancy, between what we call 18 to 22 weeks. But a very skilled operator can even recognize this in the 3rd or 4th month. So I'm going to explain this importance by a real life story actually. I don't know if there are fans of Kamala Hassan here, but one of my favorite movies of Kamala Hassan is Apurva Savakarkar. So essentially, the essence of the story is two people from the same background. They traverse through different paths of life and then come to the conclusion. So I'm going to tell this through a story of two babies, baby S and baby K, I'm going to call them, who had very similar heart diseases. Now, both of them had a condition called aortic interruption, wherein there was not enough blood going to the abdomen and the legs. So this needed to be identified and treated within the first few days of life. Otherwise, the baby was going to die without treatment. Both babies are going to die without treatments. And their story is in essence the story of the congenital heart disease scenario in central Tamil Nadu, where I live. So baby S was born in Perambalur, which is a sort of backward district in Tamil Nadu. Baby K was born in Tanjavur district. Now there is pediatric cardiac facility available in Tanjavur, which is probably the only facility for 8 to 10 districts in central Tamil Nadu. But even here, neonatal surgery is not available. So you either have to go to Coimbatore or Chennai, which is the westernmost or northernmost corner of Tamil Nadu, in order to undergo neonatal heart surgery. So how did baby S fare? So this baby was born at 8 o'clock in the morning in a private hospital in Perambalur. So the baby was completely fine. The family were very happy. This was the first baby for the parents. Everybody in the family was very happy. And then the pediatrician went back and saw the child 4 hours later because the nurse said the baby's breathing is not looking good. And he noticed that the baby was breathing very fast. So he thought this baby may need some advanced care, which was not available in their hometown. And so he referred them to a tertiary facility in Trichy, which is a bit more than an hour away. So the baby reached that facility at 2 p.m. So there the baby was received, so initial treatment was given, the baby was stabilized. And then the pediatrician at the tertiary care facility, he kept seeing the baby throughout the day. At 6 o'clock, he was not happy with the response to the treatment. So he believed he was not treating it the way it should be and that there is something else which he was missing. And he thought the thing which he was missing could be potentially a congenital heart disease. Now, unfortunately, he did not have a pediatric cardiologist available in Trichy also. So he had to refer the baby to me for a diagnosis. So the baby had, a baby who's less than 12 hours old had to make a second journey again in a new ambulance to Tanjavur, where I performed an echo at 8 p.m., exactly 12 hours after the baby was born, and confirmed the diagnosis and started the baby on some life-saving medications to stabilize the baby initially. But that was not the end of the journey. Even though we knew the diagnosis, we knew what treatment is needed, that treatment could not be offered at Tanjavur. And so after the initial stabilization, which took almost a day for us, the day after, the baby had to be shifted from Tanjavur to Coimbatore, where the surgery was performed. Now, what are the challenges facing the family? First was a scattered family. The mother and grandmothers were in Perambalur. One grandfather was in Trichy, settling the bills for the initial hospital where the baby had been stabilized. The father and one of the grandfathers were with me. And this was a complete shock. In the morning, they were celebrating the birth of their first child. And suddenly there was so much information for them to digest and internalize and understand, all within a period of 12 hours. And the pediatrician in Perambalur thought something, the pediatrician in Trichy thought something else, I am saying something else. It was very difficult for them. But more than anything else, what I could make out from the father's face was sheer exhaustion. What was supposed to be the happiest day of his life was spent running from one place to another, one hospital to another, one ICU to another. So that was the primary reaction. He was completely exhausted. Now, the cost of the procedure was approximately 3 lakhs. Both of the families were from middle-class backgrounds. So, they would be able to muster that money up. But it's not something which they could, just produce within hours. They needed time to arrange that money, and which they did not have because the child needed to be operated in the next couple of days at most. And then there was this unexpected leave from work and workplace arrangements. So in this part of the world, paternity leave is not really something, it might be a few days, or if you're very lucky, 1 week. Whereas here you are expecting at least 10 days away from work, and being middle class, you have to work to earn. So this was also in the back of his mind, like how am I going to manage that as well? And he had to do all of that within 1 day. Ultimately, the baby, they managed to do all of that despite all the stress. The baby got operated and went home well. But this wasn't the case with the other baby K. So this was the first child of non-consanguineous parents. Now, this child was born after 3 years of marriage. So, there was a lot of celebration when the mother became pregnant because in 3 years they've been trying to have a child and they didn't have it. 3 years may not sound a very long time for most families, but for this particular family, both parents were very stressed about the fact that they did not have children. The early pregnancy was uneventful. He was actually referred for routine fetal echo just because the family were too concerned. And at that time, we picked the CHD. Now, this family was also from a sort of middle-class background only. The father had just started a business on his own, very small local business, and it was just starting to become slightly financially stable. But as soon as they heard the news, obviously they were shocked and they were completely crestfallen. They could not even internalize what I was speaking to them. But then they went home, and 2 days later, the father came back to me, and then we had a detailed discussion about the diagnosis the the treatment plan and all of that. This was at the height of the second wave of pandemic. This was in May 2021. So we organized for a video consultation with the surgeon because they could not go physically to Coimbatore or Chennai and talk to the surgeon. So the surgeon also explained the management plan and all of that. So they worked out all the logistics and cost of treatment, various possibilities and all that. And the family felt that the best option for them was to deliver in Tanjavur, have the initial stabilization and then transport the child for surgery, because that might be, logistically and overall cost-wise, they've thought that that will be less expensive. And he was able to arrange all of these 3 months before delivery. So it went like clockwork. The baby got delivered. We did an echo, confirmed the diagnosis, and then stabilized the child, shifted the child for surgery, and then the child recovered completely from the surgery. So that is the beauty of fetal echo. You have a control over a lot of the proceedings of critical heart disease, at least. So we were able to take care of the 3 major challenges just because we were able to diagnose it much earlier than when treatment was required. Now, social stigma, I think webinars like these could help remove it in the long term, but we don't have a short-term solution for it at the moment. So how good is fetal echo? Now, it may not pick up all the simple CHDs, the group 1 CHDs, which Sunil sir had mentioned, but it can definitely diagnose all the critical CHDs. It comes with a caveat though. It should be in the hands of a trained operator. So someone who is good in fetal echocardiogram, who has been trained to do fetal echocardiograms, can definitely diagnose all critical CHDs. So every pregnant woman should undergo a fetal cardiac evaluation by someone who is trained to do these procedures. And now my next part is on genetics of CHD. Now, is CHD a genetic disease? We don't have a clear yes or no answer for that. What we do know is, 1% of all pregnancies are complicated by CHD. If either parent has congenital heart disease, that goes up to 2 to 4%. And if CHD is there in a sibling, it may go as high as 5 or sometimes even 10%. But if there are CHD in multiple family members, the risk may go up to as much as 25 to 50%. So there is definitely a genetic component to CHD, but probably not all CHD. Now there are certain perceptions which exist about genetics, and this is not just about a lay person or a general public alone. It even exists among doctors and sometimes even among pediatricians. So some of the myths are, genetic testing is not widely available. That is false. In today's day and age, you can do the genetic testing even in small villages in India. Now, genetic testing, they think, is only one test, one test, and that is the only test which is needed. That is not true again. So genetic testing depends on the type of problem which the baby has. So some certain problems need certain tests, whereas certain different problems need completely different tests. So it's like a horses for courses. You need to know what the problem is, and you need to order the test, the appropriate test for that problem. So it cannot be just one test which gives you all the answers. The third conception is genetic testing is very expensive. That is also not true. The prices in India are probably the lowest in the entire world for genetic testing. And they're also very widely available. People think genetic testing is of no use to this patient's management. That is also not true. Sometimes the outcomes of congenital heart treatment depends on what the underlying genetic problem is. And there are, when you have a genetic problem, there can be associated non-cardiac problems, which we may not even be aware of. So only when we do the test, we will be looking out for these non-cardiac problems, and we can manage them even before they become, unmanageable. The last thing I keep hearing is, genetic testing doesn't do anything for the family. And actually, this, and I'm going to illustrate it with a case, real life case also. This probably has the highest cost benefit ratio among all investigations we do for heart diseases, other than echocardiogram, when it is used judiciously for the right patient. When the right test is done for the right patient, it probably provides more cost benefit ratio than any other test which we do. So this is again a real life couple. They are actually from an upper middle class background. Consanguineous, married for 3 years. So the first pregnancy, a fetal echocardiogram was done by a radiologist. He was diagnosed to have a single ventricle, and there was a mention of reversal of flow in the PDA. So the complete diagnosis was not put together, but this was what we were able to find out. And the pregnancy was terminated without further evaluation. So this current pregnancy, the obstetrician had seen a scan and diagnosed some heart problem and advised Down syndrome screening at 3 months. So the family came to us at 13 weeks, which is end of 3 months. We did a fetal evaluation. So there was midline liver, there was dextrocardia, there was functional single ventricle, common AV valve, pulmonary atresia. Everything put together was one of the most complex forms of heart diseases which we generally manage. And when I compared it to the report of the first pregnancy, it looked like both the pregnancies had very similar problems. So the family were completely shattered. Their response was, why me? Why did this happen to me? And we were able to sit with them and draw out their family tree. And we realized that whenever marriage within relatives happened in that extended family, there was some of the other heart disease, even though all of them hadn't been perfectly evaluated. There was a suggestion that a death or some disability could be related to heart problems. And we did the appropriate testing for this family, and we diagnosed that they had a very rare form of inherited heart problem, where each parent has a faulty gene. But because the second gene, we have 2 copies of every gene. So each parent had 1 faulty copy and 1 normal copy. And the normal copy sort of, made up for the faulty copy, and hence the parents were completely normal. But when they actually ended up giving the faulty copy to their children, which is why each of their children had a heart problem, which was a sort of very severe heart problem. And this, can happen with 25% of all pregnancies. So every subsequent pregnancy also has a 25% risk of having this genetic problem. Now, having had 2 children up to 3 to 5 months with a significant heart problem, the family were not willing to go through this process again. And they did not want to, become pregnant again, go on for 3 months, and then realize child has a very major heart problem. And we were able to offer them a solution for that as well. So this is something called pre-implantation genetic diagnosis, wherein by IVF, the family were able to choose a fetus, baby, which will not have all these multiple problems. And the family actually were able to guide them to that facility. They've had this procedure done, and the mother is actually pregnant right now. So only by doing this genetic testing were we in a position to offer such a solution for this family. So I hope I was able to shed some light on these 2 conditions with my talk. Thank you.
Oh my God, thank you so much, Maniram sir. I mean, we were like, we never knew these possibilities. Because normal kind of scanning and all is done. Like when you're pregnant, you get all those scans and all done. But they never told that this kind of a thing really is there. So I guess we need extensive, we are not aware of the technical terms and all, as we are all laymen. But I wish we had this kind of a knowledge before. I mean, this is what has to go around, and people have to know of it. And the genetic implication is so huge. I mean, if you are aware of any member in your family having a genetical condition wherein they were, I mean, we might get a better solution rather than running around for 101 other possibilities. It's really wonderful, I think, that you have shared, and it's totally new to me. And I'm really excited. And I just wanted to add another question. Is like a stem cell research, is it like a possibility, like, and the parents, should they go for it? And is it a myth or a reality about stem research?
For congenital heart disease, probably not in the near future. But there are some other forms of heart disease where, even in India, some research is going on the potential for stem cell therapy. things called cardiomyopathies. Some of them might be, congenital or even genetic. Most of them actually. And hopefully, in the not too far future, there'll be a solution for them based on stem cells. But as far as congenital heart disease, which is our primary focus today, there are, probably not in the near future.
And another question, I hope you wouldn't mind, about organ transplant. I mean, is there any age or is there anything we have to keep in mind if we are in the future, we are thinking of having, maybe if our kid needs one when he grows up? I mean, what are the possibilities and how should we be prepared for it?
Now, organ transplantation is very much possible even in our country, even in, at least in South India, there are quite a few centers which are offering cardiac transplant. But unlike unlike the liver, where you can take it from a living person or even kidneys, you can take part of the liver from the father or mother and put it into the baby. You cannot do that with the heart. So you need to take it from a person who's what we call brain dead, who has no scope of living, who's just being kept on, in the ICU on life support. So, and you cannot put an adult heart into a child. So the problem with infants and young children is not that it's not possible. Getting a heart is very challenging. You need to have somebody of that similar age who dies, and that is not very common. And again, we saw that congenital heart disease treatment is available only in few centers in Tamil Nadu. The number of centers offering heart transplant are even less. And with heart transplant, you need to, there is a time called cold ischemic time, where within a certain number of minutes, you need to remove the heart from that person who's donating it and put it into the person who's receiving it. So that is very short, it's actually a matter of minutes. So the family have to be in the right place in the right time, apart from the cost and all the other things involved. So that is why, in small babies, it may not, or even in young children, getting a heart in the right time may not happen happen for everyone. So there are
there's a high risk
medical challenges as well, which in our country at the moment is probably are insurmountable, but things may change in a few years.
Okay, so no artificial heart and no possibility for that in your future, I guess. Right, doctor.
Again, there is a possibility of things called ventricular assist device, which sort of act like an artificial heart. But such devices for children, probably there are only 1 or 2 centers in the whole country which offer it at the moment.
Okay, thank you so much, doctor. Really, I am really sincerely saying this. I have never thought about this kind of a genetic thing that might trigger and cause this kind of a thing. And we really need to get into genetic mapping a little bit more. Parents and young couples, especially Valentine's Day, and it's happening, and they might be thinking about being family and all. It is better that they get the checkup done rather than gifting their future wife or husband whatever gifts.
I think Mahesh sir may remember this incident. A few years back, we had a visiting pediatric cardiologist from the UK. We had gone out for dinner, and then he was telling us, we have this amazing thing in the UK where for 3,000 pounds, we can, I can look at my entire genome. And then I told him, look, if you come to India, we can get it done for much less than 300 pounds. So you can actually fly first class from the UK, get it done and go back, but at a much lesser cost than what it is in the UK. So, things can be done in India, and things are actually not, the costs have actually come down since then. So it is very much possible. But the most important thing is identifying the problem and ordering the right test for the problem. So it's not like, as I said, it's not like one size fits all. So you need to do the right thing for the right child.
Oh my God, that's really good. Thank you so much, doctor. Really, it was a very refreshing kind of a thing. And the way you presented also, the pictures and all, that really connected with all of us. Thank you so much, sir. And we are looking forward to more sessions wherein we would be we want you here for sure. All of you. Because I'm sure every person who joined the meeting, they came without knowing so many facts and so many uncertainties. And I'm sure your questions, the presentations that the doctors have been presenting, it has cleared so many doubts. so many doubts, and we are in a better position to handle things now. I'm sure of that. Thank you so much, doctor. And now we are going to the next person. Dr. Srihari has just now messaged me saying that his father is not well and he's in the hospital with his father, so he wouldn't be able to take the call. And so we are just now coming to the next person, and that is one person who has to address like so many issues, but she has been a warrior in the advocacy of getting the rights of the CHDs somehow like recognized at least. And she is one who is in the advocacy mission for insurance policies and how to make the disability act wherein CHDs are also made inclusive, so that our children really, they're not just saved and given a life, but a livelihood as well. So it's the most important thing. You just cannot like leave them just as a surgery table or saying that, okay, we have fixed the heart, the life is also to be fixed. And so let me just call upon Dr. Smita Mishra, ma'am. Please, ma'am, to you. And she's a poetess as well. I mean, her poetry is so good and everything is about CHD. So moving on to Dr. Smita Mishra, ma'am.
Thank you so much for this opportunity, and I'm so impressed by your zeal, and everyone who is presenting over there has a special heart for these kids who are having congenital heart disease, and it's a great thing for me. So I start with my poetry. Huh, Sajni?
Sure, ma'am.
Sure, ma'am. Sure.
Is dedicated for rights of a child with heart disease, and it is dedicated Valentine Day from my side for the children with congenital heart disease. So this child is addressing, "Oh nation, I am your youngest citizen, who was born with a messy heart. To unsuspecting parents, they cried to see the sickness and plight of their own little angel who had just arrived. O nation, tell me how they would have escaped their own saddening heartbreak when they came to know the pain I was about to go through, the cost that was beyond this pocket. Alas, then they choose poverty over middle class income and respect over begging by selling off roof and taking off siblings from the school. O nation, where is your UN Convention on the Child Rights that no child must be denied right to grow, study, and become best and bright? O nation, can you pay my surgical bill or the cost of the prosthesis? Can you give me the assurance of insurance? Can you fight with me against discrimination? No. Why? I can't walk 2 blocks anymore. My feet are swollen. Can you give me just lower berth of train? No, but why? Oh, by law, I am not proven disabled, but I can't even breathe. My heart is racing, yet the doctor said my cardiac output is lacking. Lo and behold, I am not disabled, you say, that I must refrain from support seeking. O nation, live up to your image. Take me your social security net. I want to be rising and shining like a sun. Please take away these nasty clouds of neglect, obstructing my potential and strength. Thank you. Then I start with my slide sharing. Can you hear me?
Yes, ma'am. Apu, please, ma'am wants to share the slide.
Sharing,
yeah, host.
So, ma'am, can you make her co-host?
Yeah, ma'am is already co-host.
Okay.
I hope this poetry made sense.
Yes, totally relate to it, ma'am. Sure.
So today you have given me a topic, rights of a child with CHD. So United Nations Convention on Right of Child was adopted in 1989 and entered into force in 1990, and India ratified it. So there are 54 articles, but most important is core principles are that a child should never be subjected for discrimination, best interest of child, vulnerability should be taken care of, the right to survival and development is there, and we have to respect the views of child. So accordingly, our children with CHD are not, but they are very well protected under this these articles. So article 12, 28 and 19 and 29 and 31, they are very important. And the most important is article 23, which says your right to special care and support if you are disabled. So there is a convention and there are some provisions, but did we make a use of it? No. There are a sea of issues with the congenital heart disease, medical bills, a second surgery, marriage, sports, employability, health, life insurance, social security, and who will offer option? We need a stepping stone. This is my program, Spandan. I started in 2003 and converted it into extended family. So many of you are father or mother of the children with the congenital heart disease, but I have also a very big family of children who have congenital heart disease, who were born around 2003, and now they are going for marriage, they are looking for a second operation. So I understand what are the issues they are going through. This is my story, where you can see the paper after paper I kept on writing on the disability document criteria for cardiac disability. This you can see in 2009. I wrote a email CHD about the disability. You can see the topic is disability in 2009. And I had no primary criteria or anything anywhere. So I was just kept on working, and this was the first email was done for the Professor Rajan Tandon, who was father figure of pediatric cardiology, and he called me and we discussed again, and he told me what wrong I was doing in my document, and I corrected that. I also wrote a mail to other people, and the most important mail was written under the behest of on the behest of Dr. Rajesh Sharma. Then I discussed the issue that there was no hearing about this topic. So this I wrote to PCSI President Dr. Krishna Kumar, based on his own paper, that calculated need of cardiac surgery program getting fulfilled. What we achieve is 200 center with capacity to operate 1,000 patients per year will have approximately just a minute, we will have 20,000 plus number of patients per year, and around 2,80,000 pooled patients as adolescent and adult patient after average 14 years of 14 years from this date. So they will be looking for a respectful place in society, craving for a fruitful life, job, marriage, children. How would they know that they are disabled or they are able for the various responsibilities they are going to own? So this was a thing. Then we actually made this paper. This paper was on these questions. We made this paper. Dr. Rajesh Sharma, who is now president of PCSI, is my co-author, and we wrote this proposed method for evaluation and categorization of functional capacity of children, adolescent, adults with cardiac disease to bring them in existing social justice system by creating the cardiac disability criteria. So we must know that stepping stone, what I showed you, the Ram Setu picture, this is a small effort to create that is stepping stones in the for the evolution of further social security system. So highlight of this paper where because there was emerging epidemiological trend in India indicating the rising burden of cardiovascular diseases, and the most important development in the history of disability was that dynamic nature of disability was accepted, and that's why the diseases like thalassemia were included, and you see them in the latest Disability Act. So there is a need of social support system, yet the list of 21 benchmark disabilities, this 21 came after 7. So you know the people actually worked for their own fraternity. So 21 benchmark disabilities notified by the Department of Empowerment of Persons with the Disabilities, Ministry of Social Justice and Empowerment, Government of India does not include CVD under the newly enacted Right of Person with the Disabilities Act 2016, while the RPWD Act 2016 has acknowledged that dynamic nature of the. So here we missed the bus. We were working on this from 2009, 2011, 12, 14, 15, but we were unable to get any entry in this bus because there was no proposal from the pediatric cardiac or maybe cardiology fraternity. And we must know in 84 there was a disability criteria, a short disability criteria was proposed when the first disability document came up, but it is nowhere now. So we tried, but consensus was not achieved, and that's why we are here and struggling and moving nowhere. So aims and objective of this paper were to define the cardiac disability. What should be a baseline criteria? Because there is the one reason why cardiac diseases cannot be categorized in various disabilities format or ability format, because they are there is lot of veracity in their presentation. A small VSD need not to get any surgery. A large VSD which was not operated on time is inoperable. A multiple VSD may need a PA bending instead of total correction. So there is lot of veracity, and there was reluctance for the time. The second thing is lack of awareness, reluctance of the timely referral by the pediatricians, and acceptance for the surgery by the families. We saw the Eisenmenger in well-to-do families. The all financial assistance given by the government is is undervalued the type of procedure, and that's why the quality of procedure cannot evaluated. The machines cannot be upgraded if this much amount is allocated for the cardiac surgeries, because it's a big thing. And most of the schemes, they don't take care of extended hospital stay, comorbidity and all those things. Then there is no medical care for the cardiac patient like a patient is having meningitis and was operated by TAF. So many times the people will deny any hospital admission in the local place and will say go your tertiary care center. The cardiovascular disability is not a specified disability, so the fund allocation is also not available for the cardiovascular diseases. There is a apathy for the psychological issues, because as a first step, we are not recognizing the issues related with congenital heart disease or heart defect. Then why we will look towards the other thing, expanded collateral problems along with this. Then there is the issue of the life and health insurance, and we must know these kids are, I am not trying to make you more worried, but yes, the adult onset heart diseases, these group who underwent the surgery or intervention for a congenital heart defect are a special vulnerable group. So they need to have some security over there. Denial to avail normal opportunities despite a normal functional capacity. This is also a big problem. They are prohibited from the participating in competitive sports. Again, landing a issue in the psychological health. And there is a chance of the sudden cardiac death also. There is no chance of sudden cardiac death. There is a classification of sports. Certain sports every child can play, certain they cannot. There are pregnancy related issues. Surrogacy is a real great option. These are the things which we need to know. We have to categorize children so that we can provide them the type of sports they can play. It is not a blanket. I mean, what I mean that a blanket statement on the schooling, sports, reoperation, marriage, pregnancy, longevity is totally unfair. That is the most important thing I would like to say. So what are the things we must do? This is a chart I sent for the government also, that pre-conception, we have to be very careful about our nutrition, because diabetes mellitus, obesity, and the periconceptual radiation exposure, all those things are high risk factor. Folic acid deficiency, that is a proven fact. The congenital defect, including the heart defect, it can be there, and smoking. There are many other things. So we have to be very careful about the preconception counseling, particularly for diabetes and obesity. Then first trimester, I really want that we have to hit it hard. The moment pregnancy is declared, we should start getting a health insurance scheme at this point, when you don't know a heart is normal or abnormal. And if we go for less than 3% birth defect, less than 1% chance of having heart defect, and if we go for a optimized healthcare package in the first trimester, so second level ultrasound will be promoted, and a termination can also be done with more surveillance. So first level, and the insurance companies can be recruited into it, and optimized package can be done. There is no other time in pregnancy where you can think of a health insurance for a congenital defect. So we have to talk in unified voice about the first trimester health insurance. Then post conception, there we know what are the problem: early detection, pulse oximeter, availability of prostaglandin, and a right place where you can go for a surgery, and optimization of the CGHS ESI packages, Ayushman packages, so that every hospital can be part of the PPP. So this particular document, it has a table ABC. Table A has no or mild hemodynamic abnormalities with the least chance of progression and intervention. Table B, significant hemodynamic effect, high chance of progression and intervention. Type C, significant hemodynamic abnormalities, intervention required if it is possible. So it is almost like a Eisenmenger syndrome. You keep them in table C. And then every table has been divided into one, the heart disease unoperated, second subgroup heart disease where operation was done, like a VSD closed, no problem, then it becomes a table A. But if it is a cardiac dilatation, a valvular regurgitation, a pacemaker implantation, then it goes in table BRC according to the disability. Then systemic presence or absence of systemic arterial hypertension, and the pulmonary arterial hypertension, presence or absence of arrhythmias. So this is a very, very elaborate table have been made in this particular paper, and I am going for a web-based calculator also. So you just go through it and you will find your disease. Definitely, I don't think anybody can miss the particular disease. And you know the after that a functional capacity evaluation is needed or not, a disability certificate is needed or not. So those things can be done based on the calculator. This is a brief flow chart based on which how the cardiac disability can be calculated, which is though there is no cardiac disability as of now in the legal terms, but whenever government is ready to accept, we have a architectural classification over here, and we can provide a baseline which can be modified. So the conclusion of my today's lecture: the rights of children with congenital heart disease, tenets of UNCRC are applicable, but never been asked for due to absence of architectural baseline structure, which we can offer to government, that you do disability certification based on that, you do insurance based on that. We didn't have. But right now we have that. Health insurance for children, first trimester, insurance of pregnant women is the only way. Because after that, if you are going for an insurance second trimester onwards, it may become a targeted, once a person is diagnosed to have congenital heart disease, they will go for this health insurance, and that will not be helpful. And like the recent Star Health insurance, health insurance program is coming up, and in 2-3 months it will be floating. But what it says they will do a second level ultrasound, and if it is normal, then only they will offer a health insurance package. So it is like that. So extended warranty on the hospital package there should be, because the people who are paying out of pocket, what is happening in 7 days, 10 days package, they are not able to complete their this thing. And it is if the hospital package is extended, then they have to pay in really very high terms. So there should be an extended warranty package on insurance system, where if you are going beyond a certain period, then you can actually optimize your cost. Then consensus on CHD pre and post op, which need to be treated at par with the children without heart disease, because a person with a small PFO should not be discriminated on the marriage, on the sports, on the job profile, anywhere. Or a patient who is totally normal now and was operated for PDASD, VSD, no valvular regurgitation, no dysfunction, should be treated at par. Formation of a combined national birth defect council for rights of children is very important, because if Indian Academy of Pediatrics comes together and the various bodies, and when we talk about birth defect in single voice, then probably we are more successful. Approaching media to publish troubleshooter issues based on the article time to time. So how first trimester health insurance work? Incidence is less than 3% for birth defect. No targeted insurance if we are doing insurance just in the first trimester. If premium can be customized, it can widening the insurance net will help. It will promote a second level anomaly scan. To improve the quality of government sponsored intervention program, there should be stopping CGHS, ESI, ETC direct financing scheme. Rather, it should be done like corporate, like group coverage. For the government employees also, government expenditure will go down and the people will have better care with the such kind of insurance facilities. And the government must provide high-end insurance coverage instead of under-evaluating a procedure. That is a very important thing. CGHS, ESI, Ayushman needs to be optimized. Thank you so much. Here I finish.
Thank you so much, ma'am. Thank you so much, ma'am, for the elaborate briefing on the different things that we are looking at when we are talking of insurance and job opportunities for the CHDs and all. But as of now, is there anything that we can actually go for, like an insurance or inclusion in the job? I mean, inclusion in the Disability Act. Is there anything as of now?
Disability Act, you are out. Right now, I talk to disability commissioners and the office and everywhere. Unless it is included, disability cannot be provided. That is the one. It will fire back. If you are asking for something, they will actually take away your job. So that is how it is. If you are saying I'm not able to do this thing, then people will say, okay, you are disabled. I have seen this happening. So that is the one part. The second part is about the insurance. So one thing is there are many insurance agencies who are providing insurance for the accident and all other things other than the cardiac reoperation. That is one. I asked Tata AIG and Max Bupa, and there are 2-3 other Reliance. So if you are giving premium for 2 to 3 years, so few of them will cover the pre-existing illness. So in that case, ASD can be covered, because ASD, the time of surgery is around say 2nd, 3rd year, or maybe VSD, PS physiology, where the shunt is very balanced. So in those cases like pink top, they can be operated beyond the 3 years, then probably they can be taken into this group. So actually I talk at personal level, and the Tata AIG group says that we will, whenever there is a need arises, please inform us and we will take care of that. After 3-year premium, a coverage can be given. So there you can probably contact me and I can give the number of the particular person. So that probably can be done. So
Okay,
that
ma'am.
is what it is.
Thank you so much, ma'am. Because just now my request for insurance got rejected. Like I had opted for my son, and initially they said that it is inclusive and it was Star Health Insurance. All the documentation, everything actually contained that CHDs are included. I mean, pre-existing conditions are inclusive, and that congenital heart condition is also inclusive. But when the form was filled and it was filled like CTGA, and the PA banding was done, and he has got COVID recently. The medical team, the response I got from the insurance company was the medical team actually rejected his plea. Now, I mean, medical team would be comprising of doctors, right? So is
So
it like
the doctors will reject it. I'm telling you, there is so much bias against, because this paper, I have struggled so much. Like if I submitted it for the publication 2019, total 1 year I kept on writing they kept on saying me, why you are doing this? This is not required. This, that, there will be so much of burden on the government. There was lot of this struggle was coming from the doctors only. So, this sensitizing them is a very difficult job. And the thing is, what you said, I was expecting this, what you said me, because that is the reason. If you see this paper where we have written the methodology, what happens, the insurance is totally in India is a individual discretion. A person to whom you are, if you know a person, probably you will get a insurance for a more severe disease. And if a person is not known to you, and if he is not ready to favor you, then they will not provide you insurance, because the insurance in India is around hardly less than 10%. And that is not very successful, because most of the time people are having targeted, my coronary artery disease detected, I will go and take a insurance. So that is why the biggest culprit is government, who has started CGHS, ECHS, this, that. They are giving direct, the maximum number of people who can pay, they are from government services. Either during the service or the post service, their families are included. So the biggest number of people who are having money to spend, they are the government people. So if government people are coming under the government direct sponsorship scheme, any other this insurance scheme cannot be successful. So the more, and they are also suffering because the optimization is not there. They are like bare metal stent. They will get only that. They will have a minimal access surgery is available, but they have to go for open sternum bypass, because the minimal access, neither they will allow that a person pays by himself. They will not allow you, and they will say only government, whatever is package given, within that you have to work. So that way they are in great disadvantage. So and if you actually go for a corporate like group coverage, then the premium package is quite less. And we all in the corporates, we are covered by that, and we are very happy with our insurance facility. And if it is done by government, then the whole India will change, because then the insurance agencies will be more and more, they will be more kind. And the other thing is LIC and the government agencies, they are having so much of money. They are very particular they are very smart in denying the claims.
Yeah, they
so
would.
That
They
is
would
also, they are very smart in denying claims. Yeah. So that's why they have thousands and thousands, I mean, not millions of the rupees sitting over there. And they are not using it.
Policies are there, things are there, and everything is for the rich. The middle class who pay the taxes to the maximum, they are like given hardly anything, any chance at life. It's really disheartening, but yeah, we'll push the
middle class has I'm telling you, I'm talking to so many people all the time for last 10-12 years. Because but this is so difficult to find a person who is a policy maker in the insurance agency. I'm not able to. Just now, yesterday, there is a good news. I talked to someone and she is saying that probably if I create a good document, so she will take it to CII. And that is the first good news I heard yesterday.
That's really nice. Let us look forward to it. Thank you so much, ma'am. Now we have got one very special guest, Dr. Navneeta Shashikumar, and she is a clinical associate professor, pediatric cardiology, Amrita Hospital, Kochi. I have kept her to speak later because I am particularly all ears to her. My son is an adult CHD, and she is closely associated with adult CHD and post-pandemic, pre-pandemic, all those things, what changes they have to bring about in their lifestyles, what we are looking at, and the need for follow-ups, because most of the people have lost contact with their hospitals. Even I couldn't get back to my hospital because of the pandemic. So we are all worried, like, what is it that is in store if you do not have a proper follow-up strategy, or we've missed the follow-up. So I would really request Dr. Navneeta Shashikumar to speak on this topic. Hello, ma'am.
Thank you all for having me here. I'm just looking for screen share.
Apu, ma'am needs to be made a host.
Yeah, I'm doing the share. Yeah, I think it's working. Yeah, it is working. So good afternoon, everybody, and it is such a great pleasure to be here and an honor. Thank you again for the invitation. And so today it was great listening to the talks and the discussions, especially the one on insurance by Smita ma'am. It's good to know that there are opportunities and avenues which can be explored in the future. So I will be focusing on follow-up care of congenital heart disease patients. During the talk, I will be referring to some medical terms and some of the problems that congenital heart disease patients could encounter on follow-up. Please be assured that the only intention is that knowledge is power, and knowing things will help us to deal with things better. So, if any of the matter that I'm presenting is concerning or worrying to any of you, please reach out to us. And we are always there to help you out with your queries, whether it is related to medical, personal, social, financial, whatever. So it's just a disclaimer in the beginning, because when you talk about follow-up, I will be forced to talk about a little bit of medical conditions. So to start with, yes, I would say that the sky is the limit, and this man is one of the best examples for that. This Sean White, who's an Olympic gold medalist for snowboarding, actually. He's been operated thrice for tetralogy and pulmonary atresia. So first surgery and then conduit replacement. So, so the gist of the story is, yes, there will be hospital visits, there will be multiple procedures, but still, there's no stopping life if you really want to go at it. So coming to the topic, I would say that care for congenital heart diseases is a continuum. It starts with recognition, then a proper diagnosis, and triage of who needs emergency surgeries or procedures and who can wait, referring the patient to appropriate center, for procedures or surgeries. And an important part of it is transport, especially critically sick babies. And then comes the actual treatment part. And the coldest part of all is follow-up. Okay, the treatment is done, and now the coldest part of all. And at the same time, that is the part where most of these patients would be spending most of their time in. So the active part occupies less of the time, but then, when we say follow-up, we are looking at a lifetime perspective, like, what happens to these children as they grow up, as they become older, what are the problems that they could face medically, as well as socially, personally, and all, and how can we help these children as they go through it throughout their lifetime. So yeah, when we talk about follow-up, the first thing that comes to our mind is who needs follow-up and when do they need follow-up. So what I would like to point out is that even if two patients have the same diagnosis and they've undergone the same treatment, ultimately no two patients are the same. The names of the diagnosis would be the same, the names of the procedures would be the same, but no two patients are ever the same. Each patient is unique. You all know it better than me. And each patient has a history of their own. And that is what makes like professionals like me interested in this and like hooked to you patients and like, trying to do as much as possible to help you all. It's actually a great privilege for us to be part of your stories. Each of you are different. Each of you have different anatomies, and each of these patients will have different physiology, and accordingly, their needs will be different. So the timing of follow-up and who all needs follow-up will also be different based on this. So one important thing that has come up in the last few years is like, in giving importance to both the anatomy as well as the physiology. So there might be two patients operated for ventricular septal defect, for example. One of them might have absolutely no residual shunts, no pulmonary hypertension, the lung pressure is normal, nothing, they're on regular follow-up. There is no major or active physiological problem going on at that point of time. But another operated patient with a ventricular septal defect might have some other associated issue, like a pulmonary hypertension, or like, on follow-up, they might develop some new issues. So even if the baseline anatomy is the same, they can go through varying stages of physiology. So based on this, what frequency of follow-up is needed will also change. So this is quite useful because, as I said, sometimes the long-term issues that we come across might be directly related to the disease itself, but sometimes it might be unrelated. Like some of you might be aware that the aorta, which is the biggest blood vessel in the body, which carries blood from the left-sided pumping chamber to the whole of the body, actually. So this aorta can enlarge in some type of congenital heart diseases. Even after operation. So it can happen in a variety of diseases actually. It can happen even in patients with simple like bicuspid aortic valve. It can happen in operated patients with tetralogy of Fallot. So this aortic enlargement has nothing to do with the actual underlying disease, but then that is something which we will focus while on follow-up. So some points that we need to be looked up on follow-up might be directly related, some might not be directly related. Also, I would say that as we move across the lifespan, patients will move from one class to another. Like, bicuspid aortic valve is being followed up, underwent one balloon dilatation for a narrowing of the valve supposedly. And it was well relieved and the patient was on follow-up over 5 years, 10 years, there is a small possibility that it can occur again. And when the stenosis or the narrowing worsens again, they move across classes. So the physiology changes and we need to track that change in physiology and intervene at the right time. Too early interventions are never good. Too late interventions are never good. So that is exactly why we need regular follow-up so that we can track the changes in physiology and decide on what needs to be done at the right time. It should never be early. It should never be late. So that timing can be ideally appropriately done only when patients are on regular follow-up. And so regarding follow-up, you all know that, as children, the follow-up has to be done by a pediatric cardiologist, and it is best done in centers where it has support for complex congenital cardiac surgery, anesthesia, post-operative care, facilities for interventions, including advanced interventions and cardiac imaging as well. As we move across life into adults, as we grow up into adults, we need more people and more specialists around to take care of these children as they grow up into adults. So the role of fetal cardiology was beautifully explained by Dr. Maniram, because especially congenital heart disease patients, when they conceive, when they are giving birth to their children, they have a slightly higher incidence of congenital heart disease compared to the general population. So it is good to have fetal cardiac surveys. And when adult congenital heart disease patients go through pregnancy, based on their physiological stage, most of them, or at least a significant proportion of them, will fall into the high risk obstetric category, where we need support from obstetricians who are experienced in handling such pregnancies with the support or with input from adult congenital cardiologists at each point in pregnancy. Also, as they grow, some of them will have problems with pulmonary hypertension, and it is important to have services of specialists in pulmonary hypertension as well. So as they become adults, they continue to be followed up. They need more and more specialists working in coordination to help through each of their stages. Not only cardiac diseases, but on follow-up, like in the COVID times, we all know that, if during the COVID times, we know that COVID itself, although the if you compare the number of children who are affected by COVID and the number of children whose hearts are affected by COVID, it's only a small percentage. But when it gets affected, sometimes it can get very serious. So, sometimes non-cardiac disease can affect the heart. And at that time, you'll need support from the cardiologist to help them tide over that. And suppose, suppose a congenital heart disease patient develops a surgical illness, like an appendicitis or, anything of that sort. And then when the question comes about general surgery and anesthesia, an input from the pediatric cardiologist or the adult congenital cardiologist is necessary for safely performing anesthesia as well as surgery in these patients. And more important is when it comes to pre-marriage counseling for men as well as women who are survivors of congenital heart disease. When it comes to contraception, because not all methods of contraception can be utilized in congenital heart disease patients. Some of them have their own advantages, some of them have their disadvantages. So each patient is different. And when it comes to contraception, an in-depth discussion with the cardiologist as to what method is most appropriate for this particular patient is important. Pre-pregnancy counseling, that is another area where follow-up plays an important role, because some of the medications that the patient might be taking might not be advisable to be continued during pregnancy. So we might need changes in medication. And as I already mentioned, if there are residual lesions, or if there are physiologically significant lesions, or like pulmonary hypertension, or new onset arrhythmias, any of these sorts, managing those pregnancies, needs a little bit more attention and care compared to those without. So an adult congenital heart disease patient with pregnancy is best managed in a center where we have obstetricians who are experienced in handling high-risk pregnancies, supported by a team of cardiologists who are experts in each of the subspecialties in cardiology, which includes electrophysiology, sometimes pulmonary hypertension, in addition to the adult congenital heart disease specialists. And as Dr. Maniram already discussed, there is a recurrence risk in children, and this is one aspect which we would like to consider. It's different across different CHDs. It varies whether it's a mom or the dad which is affected. So discussion regarding that, and how to plan the pregnancy, the recurrence risk, and planning the pregnancy according to that is also very important. And I would also like to mention that, when you look at adult congenital heart disease in India or in Kerala, we do not have much data. So I would like to bring to your attention that we are trying to collect some data through this study, which is called the Approach International Study. So this, we have started at Amrita. It is an international study, including 80 centers across the world. And what we are looking at essentially is the quality of life of adult congenital heart disease patients, completely from a patient's perspective. So it is all questionnaire based, and we are looking at the patient's perspective of the medical, personal, social, and financial issues that they are going through. And what this study aims is to collect data which we do not have as of now, and consolidate this data and use it for changes in policy, both from the medical as well as as Smita ma'am was referring to, from a policy point of view, insurance, social support, all that. So this, we are hoping that would be a major step forward supporting adult congenital heart disease patients. And then another thing that I would like to bring to your notice is that in the recent years, there have been multiple studies which looked at cardiovascular risk, which means, the coronary artery disease, which blockages in arteries or what predisposes to stroke in adult patients, like older patients. So there has been some studies which point that when congenital heart disease patients grow up, these group of patients, compared to general population, they have a slightly higher risk of contracting or having these diseases as adults. So it is important that we follow like healthy lifestyle, because these are preventable. That is the most important thing. So these stuff are unlike congenital heart disease, which is not in our control to a great extent, except for the pre-implantation genetic diagnosis that Dr. Maniram was referring to. So mostly it is not within our control, but the cardiovascular diseases in the adult, which includes coronary artery disease, stroke, heart failure relating to these. So these are preventable to a great extent. So if we know that our congenital heart disease patients are at higher risk for these when they grow up, we can institute preventive measures at the right time, even if they develop like risk factors for these, like hypertension, diabetes, dyslipidemia. We can treat it aggressively so that we can prevent complications from developing later in life. And so this is one thing which, this is another aspect of why congenital heart disease patients need to be on regular follow-up with specialists who know like over lifetime what problems they can develop and how we can address them. So what influences the development of these is an interesting area of research, and hopefully by the end of this year, we'll be getting into some research for in that area as well. So is it the stress of the procedures and the interventions, or is it the timing of the procedures, stressful procedures as a neonate, as an infant, or is it psychosocial factors which predispose them to this cardiovascular diseases in the congenital heart disease population as they grow older is unknown as of now. And this is another area of potential research we will be taking up in the coming years as well. So thank you all for your patient listening, and I'm very happy to take questions if any.
Thank you so much, ma'am. I mean, being a mother to a like adult CHD, it's tough. But I guess with all these things, research and all that's going on, I hope it is a brighter future than we people really were apprehensive about. Maybe I don't know. I mean, I'm kind of having mixed feelings, I would say, because. It's really difficult because we know so much has to be done, so much of research is needed, and we are still taking baby steps. And the whole thing actually may have started like years back, right, ma'am? So, anyways, thank you. So, yeah, actually, when I look at these small kids, I always feel like, oh my God, what's going to happen to them when they reach the age of my son? Because it's been very tough a battle for him, and it's okay. Like things are going to be better in the coming years. Thank you so much, ma'am. And now it's now it's like time for us to call the heart moms and dads who are patiently waiting to like share their stories, and their stories would really take us to places which have common strengths, but still they have a common thing that go along being a CHD parent. So here we have two CHD moms. Okay, one is Tarana Tabassum and the other one is Srishti Grihotra Reddy. And to share the story, so we'll start with Tabassum. I mean, Tarana and Tabassum. Yes, come on. Tarana, yeah, please, yeah.
Hi everyone. Thank you so much for having me here. Can you hear me?
Yes, you're audible, ma. Yes.
Okay. Thank you so much for having me here. I'm more than happy and grateful to all of you. And I'm happy to being with such brilliant and experienced minds. I'm sorry for not being able to address everyone. Please receive my heartiest gratitude, everyone. So it's so overwhelming actually to see so many people working together for just to make our warriors' life normal, or at least accepted in normal world. I've mentioned my CHD community members that I am actually so emotional, and I might shed some tears while sharing my experience here also. So here my story goes. My journey as a heart mom started quite a while prior to my daughter's birth. I was 22 weeks pregnant at that moment when we got to know about her diagnosis. That was August 23, 2019. I still remember when the sonologist said her heart seems different. Hearing that, my heart skipped a bit. Hypoplastic heart, a single ventricle. That's what she said. I was blank. I actually had no idea what it was or how this will change my life entirely. We had to test few times to be sure about her diagnosis, but none of the doctor visits gave us hope. We only had one way open and suggested termination of my pregnancy, as the stage surgeries were not available, practically available in our country. I'm from Bangladesh, the neighboring country of India. So the next couple of days after finding out was the hardest to deal with. Days were so long and like a roller coaster ride, to be honest. No matter how much I tried to focus into other stuffs, I ended up finding myself in an unmapped route. There were so many questions that I didn't know the answers of. And there were questions that no one might know the answers. I found so many groups, so many individuals like me who were almost in the same journey as mine. Again, every journey was different. There are so many defects in so different combinations, which makes every case is unique and different from one another. Yes, it's a crazy little tiny heart can have different defects in different combinations. So end of the day, I had a huge number of unanswered questions that left me restless. I tried my level best to stay strong, not to worry, and to be as positive as I could. But the fear of unknown actually didn't let me. So on September 10th, we flew to India, Bangalore, Narayana Cardiac, just to get the answers of some questions that we had. That time we weren't sure if we will ever hear something positive from the doctors there, or we will still get the same responses we got. What we knew was we were ready to give my daughter a chance. We wanted to give ourselves a chance for the last time. We wanted Allah to help us get through the tough time. That time we were told to be prepared for the worst. We have to be present in Bangalore at least 2 months prior to my delivery, as our baby might need surgery in the first week, and rest 2 or 3 surgeries depending on her condition. Thus, our stay could be for 8 to 10 months or around a year in India. We came to Bangladesh, and rest of the days were even more scary. I couldn't imagine how will we manage the situation, and how can I stay there for this long? Who will be there with me the whole time? How will we manage the expenses? Because the treatment is quite expensive. I'm actually adding all the details just to make everyone understand the struggle we had to face just to give her birth, only with the hope to keep her alive and try our level best to make sure every needed treatment was available on time. During my 33rd week of pregnancy, we went there and wait till her birth. Though it seemed she might needed the first surgery within the first week, but luckily she didn't need it. She had HRHS, CCTGA, severe pulmonary hypertension, PDA, ASD, VSD, and so on. Her PA banding was supposed to be done at 2 to 2.5 months old. So we were suggested to come back to Bangladesh and revisit India when the surgery was needed. When it was time, we couldn't make it due to the COVID lockdown. It was March 17, the first lockdown, when it was declared. Our borders were closed. We didn't have any way out. So we went to a cardiologist in our place. And according to him, Yusra should wait till 6 months. And after that, her PA banding and atrial septostomy will be done. So we were relieved. We were hoping that we had the hope that by the time comes, situation will come back to normal and we will be able to go back to India and get her surgery done. But everything happened just the way God planned. The projection of ours didn't actually work out. Her condition was getting worse day by day. We went to another doctor this time and he was shocked at us and he just said, why did we wait so long? She was 4 months, 22 days old at that time. According to him, it was already late. Even if we try to do the surgery now, it will be hard on her and she might not make it. He also suggested if possible to get it done in India, but as it was not possible due to the lockdown, we decided no matter what, we'll have to try it here. So we requested the doctor for the surgery and said no matter what happens, we will accept that, even if the result is negative, because it was hard to see what our daughter was going through at that moment every day. So at 5 months, 11 days of age, her first surgery went well by the grace of Almighty. And after a lot of struggles, the Glen was done at 15 months and Narayan again. She is now waiting for her fountain. So there are actually a few points that I wish to put emphasis on. I tried to explain my scenario a bit in detail just to make audience realize the immense struggle a CHD parents have to endure if the required treatment of the child is not available within reach. With the financial burden of treatment, the associated cost of traveling and living there also makes the load heavier. So alongside the mental and financial pressure, many CHD parents, especially CHD mom, have to experience the bitter sides of kids. I was lucky enough to have my husband and my family by my side. Everyone's case is not the same. I have seen many cases, the CHD parents are tagged as sinners, and the kid is a result of some sin or labeled as curse. It's actually so hard, but it's true. I've talked to so many parents, and their case is also the same. So for this CHD parent, the thought of having another kid is also so scary because we have the fear, what if the next baby suffers the same? And to add another thing, I'm actually very much vocal about my daughter's condition, both in person and in social media as well, just to give information about CHD and where to go for treatment and give some mental support to those parents who are in need. My daughter's condition was diagnosed on time, and actually we had the opportunity to handle the situation. We were ready. We knew something bad might happen to us, so we were ready mentally also. A large number of parents doesn't get that chance. Many babies lost their lives just because the condition wasn't diagnosed when required. So actually, if the newborn screening system was done in proper way, I think a large number of CHD kids would be diagnosed on time and have the chance of living. Another thing, there is one question that's so normal for us as parents, but puts me in a place I don't want to be, is how can she be sick? She looks so normal. She is like any other healthy babies. She doesn't look she has any problem. Actually, the whole CHD thing is so tough for us to deal with no matter how old our kids become. And one good points Dr. Sunil Sir discussed about marriage and pregnancy sometimes makes me sleepless. Still, we are waiting for the best thing to happen with our babies. We are hopeful good days will come. I haven't mentioned before, another point I forgot, that I had the fetal echo done the second time once my daughter's first diagnosed. I didn't disclose that we know about her problem already, but we went there anyway. So the echo was done. Sorry, that was anomaly scan. I'm sorry. The scanning was done, and while scanning, I just asked the doctor, "Is my daughter okay? Does her heart look normal?" And the doctor said yes, yes. And I was shocked by I didn't say any word. I said nothing. I just came with a normal report that 4th chamber heart is visible. And that day I went to another doctor to get the fetal echo done, and the result was same as before, that she has the single ventricle. Actually, that incident made me think there might be many mothers who actually got the normal report, but their kids have some problems. I don't know why this happened. I don't know. So I hope this thing never happens to anyone. Okay. So I have come across a lot of CHD parents or caregivers from Bangladesh who are unable to give or continue the required treatment for their kid due to financial issues, or again, a lot of are not fully aware of the severity of the defect. They only know the hole's gonna heal on their own. It's just holes in heart. They can be okay with it without surgery. So my request to every doctors from every places dealing with such patients is to spare a few minutes and make them realize the whole thing properly, so the parents actually get to know the issue, the severity of CHD. There are so many other facts to discuss, but I'm sure every topic has been covered by this whole session, because we all actually go through the same struggles and pains, though we have different stories, but our journey is on the same track. And again, thank you everyone for hearing my story. I'm kicking off now.
Thank you so much, Tarana. As you said, the journey is the same for all of us. We all have something to begin with, and our journey would never end till we give justice and a place to our kids, right? The rightful position in the society. So now let's move on to Srishti. Come on, yet let us hear your story as well. Let everyone hear.
Sure.
Yes.
Thank you so much, for providing me an opportunity to be a part of this community, first of all, and thanks to the entire group of people, seasoned professional from the medical fraternity, wherein at least through this platform we are getting an opportunity to share our stories and which are being heard over here. However, when we discuss or share with any normal parent, I mean parent with a normal kid, I mean, they just show us simple sympathy because they cannot relate with us. And that sympathy honestly is not needed, because now we are running with the journey, we are going through this journey, and we are used to it. That again, next step is something that we need to look forward to. My journey began in the 8th month of my pregnancy. Again, I would say that we were fortunate enough to get to understand about this particular disease before my son's birth. But somehow it was, I would say, like my gynecologist suggested me to go for a fetal echo, which again, I was completely unaware of that term. I did ask her the reason why this is suggested in 38th month of my pregnancy. So she simply said it's a general process, routine thing that we are going ahead with. I got it done. When I reached to my sonologist, she surprisingly asked me why it is getting done at this stage. She herself asked me that. So again, and it was somewhere around 8 p.m. when I was getting my echo done, fetal echo done. And to her, so I could figure out that there is something really not usually happening over there, because I could figure out from her face. And she suggested me to come back the next morning to get the echo done again. I did ask her, like, why is it so? Then she just tried to, simply give me the reason. At times, the baby's position is not accurate. You can get to know in the another scan. So I again, it was again a complete nightmare on 2nd of June of 2015. That was the 8th month of my pregnancy. I went back to the clinic on 3rd of June morning, wherein finally she disclosed, after having that 2-minute scan, that I'm referring you to Dr. Vikas Kohli. He's a great cardiologist, and he will do he will again issue the sonography report, I mean this fetal echo report, and he will diagnose the thing. He will disclose it to you. Then only I'll be disclosing the final report. I mean, since Dr. Vikas Kohli is a busy person, so of course, without wasting or waiting for more time, I went for another fetal echo with Dr. Rajesh Khurana in Delhi itself. And in 5 to 6 hours, when my reports were disclosed, I got to understand it was tricuspid atresia. And completely being unaware of this medical term, I started finding everything on Google. And Google helped me to understand. I mean, I could find it's like it's a process of 3 surgeries immediately after the birth, and then one would happen somewhere in the 10th month, and then third would happen before 3 or 4 years of age itself. I went back to, that day, 3rd of June, it was complete from one place to another. I was running along with my mother, finding the reasons and then for the next step for that particular thing. I immediately ran to my gynecologist stating that this is something which has come out. She herself got into the surprise while I was unable to understand why it happened. My earlier sonography reports were showing the normal 4-chambered heart. And we were really not able to believe the fact that this is something which is going to be happening with us. But yes, it took me almost a week or 2 weeks of time to accept the fact that my unborn son is going to be getting all of these problems, heart defects, CHD and all. Though then I again, we also try to consult with a couple of cardiologists to find out if, sorry to use this term, if this can be terminated. Because we were made so scared of forthcoming situations like 3 surgeries, open heart surgeries. I mean, that was completely scary for all of us. But then I had to change my gynecologist as well. I got my delivery done eventually with in La Femme Fortis, wherein the immediate next step was planned that my newly born son was supposed to get shifted to Fortis Escorts Heart Institute in Delhi itself, since I am based out of Delhi. So it was little easier for us to figure out the overall situation and accordingly plan the next steps. Like Adidev, my son, who is now 6.5 years old, he got shifted to Fortis Escorts Heart Institute, and under the guidance of Dr. K.S. Iyer and his team, his first surgery was conducted on 10th of August, 4 days after his birth. It was BT shunt, which was done. Then, of course, the journey began, wherein a lot of follow-up visits, a lot of I would say fear which started coming into our mind. What is going to be happening next? Even a small thing like a cough could make us so scared that we used to run. We used to rush to the doctors immediately. Then when he was 10 months old, his second surgery was performed. And when he was 4 years old, his third surgery, Fontan, was performed. He is fortunately, touch wood, he's a happy-go-lucky child right now. He looks really normal when we see him, when one sees him. But at the same time, there's always a fear in our mind that what's going to happen next. So the journey was really not so smooth. It was completely full of roller coaster ride, and I'm sure in the coming time also we are as a parent, we are prepared to provide him the best medical treatment as a parent that we can do. But at the same time, from the society, from the government side, we do expect some kind of support. So one, of course, I have certain questions from in my mind since he has been born. One, of course, as other my fellow parents said, why me? Why us? But eventually, since we accepted the fact that it is with us, we are strong enough to face these situations. That's why we have been selected by God to carry a CHD child. And now we are completely prepared to face the situations, because seeing a child, with the open heart surgeries, with all those scars and sutures, was very difficult, was very, very difficult. If we have seen our child in that situation, I'm sure we are ready to face any kind of a further situation. So I personally feel that I'm a strong woman, and I'm sure my fellow parents are also much stronger than me as well. But yes, while we are discussing on this topic, I have certain questions in my mind which I would like to put across. I'm sure most of them have already been covered in this session so far. But yes, what I need to understand, while Dr. Maniram was mentioning that fetal echo should be done somewhere between 18th to 22nd week of the pregnancy. I was never being guided by my gynecologist to get this done at that point of time. So had it been a case that if I was being told or maybe directed by my gynecologist, probably we would have got to know about it on that particular piece of time. And accordingly, probably the situation would have been different, I'm sure. I mean, so that is one concern. And I'm sure many mothers, many parents like us, they do not get to know the similar situation like us. And what about other parents who are going to be having CHD babies? So that awareness I would like to emphasize needs to be created amongst doctors, amongst gynecologists, or as Sajni ma'am also mentioned about, ASHA workers should also be informed about it, so that the expecting mother should get this done within the timelines only to find the results. Second, of course, the same thing was also being mentioned by Tarana ma'am, wherein what is the probability or possibility of our second baby having the similar disease? Because that is something because of which I cannot even think of planning my second baby, though my son is 6.5 years of at the age. And I mean, I cannot imagine planning the second baby because of that fear. Then I would also like to understand with a growing age, what we get to understand as a parent, that there could be a possibility of some other disease that might come with time. So, I mean, to be very honest, I'm not very much aware of all those like expecting problems which may occur with time. So I want at least some guidelines or some kind of, as I mentioned in my earlier conversations, also some kind of manual should be provided to the parents like us, wherein we should be readily prepared, like with age, like maybe at certain age of time, a liver thing should be, taken into consideration, and then accordingly proper care can be done. So this is my third point. Then, of course, the same thing, the cost of the treatment, because when our son got diagnosed, I mean, in my 8th month of pregnancy, though we were, as I mentioned in my earlier thing also, we were fortunate enough to got aware of this particular piece. So we did arrange finances. We got the personal loan done, and everything was being arranged. But yes, what if we would have got to know at the time of the birth? I mean, I'm sure at that point of time, it would have been really very difficult to arrange the finances to money. Though I'm a corporate employee, so I do have corporate insurance. But again, there are certain like benchmark and limit to those corporate insurance, like some insured amounts as well. So at least personal insurance or retail insurance should definitely be provided to parents like us to cover our CHD kids, so that future treatments can definitely be taken care by us very well. Yeah, so this is something which I wanted to share with all of you. And the problem remains definitely common for all of us. I mean, I'm sure while Amod sir, Tarana ma'am, we all have shared our concerns. The problem somehow, the concern somehow seems to be really common. But yes, we do expect answers and solutions to them. Thank you.
Thank you so much, Srishti, and we are sure that we would arrive at some solutions, like maybe not immediately, but in near future, because we deserve that kind of a solution, right? We did not ask for this kind of kids. We were given because we are considered that strong, I guess. So we'll strongly go forward and get something done, right? So next up, we have a CHD adult, okay, and he would like to talk with us about his journey, Mr. Rajdeep Singh. Yes, Rajdeep Singh. Hello, you there? Rajdeep?
Hello. Hello.
Yeah,
Hello.
please.
Hello, everyone.
Please, ma. Yeah.
Yeah, I'm Rajdeep Singh, and I'm 32 years old, and I'm a CHD warrior. My voice is audible, na?
Yes, yes. Your voice is audible. Yes. Yes.
Okay, ma'am. I just made an introduction that I'm 32 years old, and I have gone to 2 surgeries. One is AVR, aortic valve replaced, to mechanical, and ICR, intellectual cardiac repair, in 2016. I was having a hole in my heart since childhood, and since I was very active at that time, and after surgery, I'm also active. So in 2016, I came to know that I have a hole size has been increased to 24 mm. And for that, doctor told me that the surgery will be done. And there is the wall has been damaged with that. Then they changed the aortic valve to mechanical, and they have put a patch for BSD closure. And after that, they provide me the medicine. I'm on blood thinner. So by going forward, I have to take care of the vitamin K. I have to take care of when I don't take vitamin K in excess. That, and you can see the picture that I have shared on the PPT. The CHD, after surgery, my life has been changed a lot, and perspective of life has also been changed. Appu, can you move to the next slide?
Appu, please change the slide.
Yeah, this was my journey. So I was there in the hospital at that time. I was moved from ICU ward to the normal general ward. and I stay for 8 days in general ward, and I got discharged. And after surgery, I was given a 3 months time for recovery. And since then, I was not allowed to use a cell phone due to radiation, and only I will able to read the newspaper and novels. My sister suggests me to read novels if you get bored. So I that's now also become one of my hobby now to read books. So next one is the challenges that I faced during the surgery as the funds and the physical health, because when the surgery is done, it actually body become uh, so weak, it needs food on regular basis, a little bit of exercise. They ask me not to push anything, ask for a help whenever you need, ask for help. Don't do it by yourself for only for few months. After that you can do that. Physical health, mental health, and there was surgery trauma also, and fear of death. That is also one of the major, because at that time when we had to go for the surgery, the doctor has to put a signature that then anything would happen, it will always be on your hand. That's kind of the scary part, that what will happen. So next is can you move to the next slide, Apu? Yeah. My concern as a CHD child is what career should we choose, and what opportunity do we have in future, keeping in mind that we may face a problem in future, same problem, and the difficulty in finding the life partner as a CHD, and or can we have from healthy babies, or the problems can be transmitted to them. And my concern is also that how long will the aortic valve will efficiently work? Do I need another surgery in future? And what is the life expectancy of a CHD child? Is every child need a surgery in the future, or it's depend upon the patient to patient? And and I just want to know that which hospital should we choose? Because as someone being as CHD a child, and he became adult, so he came to know about his problem, whom she should consult, and he don't know about anything, that who will be the best doctor and where it has to be done. So there's unapproachable, how to approach that. So I have some suggestion that if that CHD kid grow up, there must be follow up, that he must try to accept himself, that he is unique and special, and he has to take care of himself first. He can, no matter what everyone say, and he has to make schedule and reminder for the medicine. I have a smartwatch. You can see that I have a smartwatch to remind me every day at 7 that I have to take a medicine. So I never forget that. And I make a proper follow the doctor and try to eat healthy. That and I will say that thank you and given me the opportunity to speak. Everyone, the doctor, Christy ma'am, and Appu, for giving me an opportunity to speak and share my story. Thank you.
Thank you so much, Rajdeep Singh. I mean, you're our hero, right? You have gone through all the ups and downs, and you're standing tall. You know, you're an inspiration to all the mothers over here. When we look at our kids, you'll be thinking, yeah, they are going to live strong and be responsible like you are, taking your medicines and taking good care of yourself. Thank you so much for sharing your story. Now, I'm just, yeah, thank you so much. I'll just add, there is a request from a parent of Amira, and she really wants to share her story, and I cannot say no to her. Okay, so let us hear that story, and let us see what she has gone through. Parent of Amira, you are there? Amyra, that is how, I don't know whether I pronounced it right. Are you there? Yeah, yes.
Yes, good afternoon, ma'am. Good afternoon to all present here. This is Nancy. I'm Amira's mom, Amira. So I just really I want to share my story with all of you. You know, when we are prepared for a thing, when we are ready, it's very smooth thing to go. But my Amira, when she was born, there was not at all any problem. She was she was a normal child till 3.5. She was very normal. Not even fever we can say. Not even fever she was having. Everything was going on smoothly. No problem was there. Suddenly she got fever, and the fever was too high. It was around 105 and 106. And you know, it was like first time she got sick, and we were like it's just normal fever, and we go to our pediatrician, and he was on vacation on that time. He was on vacation, so we got her admitted in a hospital in Ludhiana, DMC hospital. So I was thinking like it will take a week, and then we'll be back home, and our life will be very normal again, like we were leading a life. But you know, it took 7 days, and the fever was going on continuously. The fever was 105, 106. It was not coming down. And then the reason could not be diagnosed, like why the fever is there. Was no no COVID was not there, no any other issue was there. Like all the tests, blood tests were done, everything was done, but the reason for the fever could not be diagnosed. Then the doctor decided to go for echo, and it was the first time. Like I was surprised that what is this echo, what is the reason why echo. We have heard of blood test, like if the fever is continuous, then go for that malaria test and all the blood tests, but why this echo? This question was like, still I can uh, I have that feeling that why echo. Then I was like crying and crying, and my husband was like, don't worry, kuch nahi hota, it's just normal, it's just normal. But we go for echo, and then that was the first time we, like, it was diagnosed that there is a vegetation in her heart. And the doctors, like, they were looking at us, this is the child who is having vegetation, and everyone was looking at us like what has happened to us. We were not aware of at that time that what is vegetation and what are these problems. And then after that, when it was diagnosed, the doctor very normally told us that we will continue with some antibiotics, and that that vegetation will automatically will be removed, like when the antibiotics will go on. So they started that medication of antibiotics, and like still the fever was continuous, and it was the 10th day there. And we were so, like, the fever was 105 and 106. We were not relaxed at all. So we decided, the doctor, at that time the HOD was there, Dr. Puneet. She advised us to shift her in any other hospital, like you can shift her to Delhi for better treatment. Then we decided to shift her, and on that day my husband took the appointment in Fortis Escort in New Delhi. And then at night at 12 o'clock we shifted to New Delhi, and it was we have to travel for 5 to 6 hours, and it was like very difficult. My child was perfectly fine. In between, like, what happened, we were like, I can't explain that the feeling was very, very, very weird. So at that time we were shifted in Fortis Escort, and if policies were done like insurance, we were not like afraid of the charges and all. It was, everything was fine, but our child, I want her to be fine. And at that time when we were shifted to Escorts, Dr. Radha Krishna was there, the cardiac. So at that time he told us that it will be fine with the medicine only. We will go with the medicine first, then if it will not be cleared, then we have to go for the surgery. And when I heard of surgery, I was like, gone. Why surgery? What is the need of surgery? I was shouting like, I don't want my child to be treated like this, that no surgery should be there, no surgery should be there. But fever, I was, I'm not able, I don't have the words to explain that feeling. But still, we have to make her well. So that's why we admitted her there. And then medicines were going on. So high dose were, they were giving like many medicines, 4 to 5. I can't even explain the tablets which they were just melting it in the fruity and we were giving it. It was too difficult to give medicine, but still we were doing it. And then when it was the 12th day in Fortis Escort, it was the fever was still, it was 105 and 106. Then Dr. Radhakrishnan tell us that we have to go for surgery. Then it was like, okay sir, it's fine, you go for the surgery, but at any cost, please make her well, make her well. We were ready for the surgery, and then they sent us to the surgeon, Dr. Iyer. And when he denied, when we asked him to get the surgery done, Dr. Iyer denied that I am not going to do this surgery. And the question was why. I asked him a lot that, sir, why you are not ready? Is there any risk? He said that there is 100% risk your child cannot be saved. And I was like, what is happening with me? It was just fever, and what has happened? There is 100% risk. What is this? I was just crying and crying in front of her. She was looking at me, Mama, what happened? Mama, what happened? But that feeling was weird. So then Dr. Radha Krishna, Dr. Radha Krishna was like God. He suggested us to get her shift to AIMS, from Fortis Escort to AIMS. And then Dr. Radha Krishna, they took the appointment, they did everything, and we were shifted to AIMS. And then my child was saved by Dr. Raj Shekhar. He was like God to us. Within the next day, we shift to AIMS. The very next day, Dr. Dr. Raj Shekhar came and he did all the formalities. And when he asked us, he told us about the surgery, about the risk and all. I was like, no, it cannot happen. It cannot happen. But still, we have to go with it. And then the surgery was performed by Dr. Raj Shekhar, and the surgery was successful. And Dr. Raj Shekhar told us that I will like replace the valve, but he just removed the vegetation, and the valve was not replaced, it was repaired. That was a wonderful thing happened with us. And at that time we were there for after operation, after the surgery, 40 days more we have to be there for the antibiotics. And we got best treatment there in AIMS, and best doctors, best environment. I am very thankful to Dr. Raj Shekhar for the best treatment given to my daughter. Wonderful Dr. Raj Shekhar. We are like, I can't even explain that how I am very much thankful to Dr. Rajshekhar. He saved my daughter, and I am very grateful to you. So after the surgery, still we are facing like issues. Like she said that, Mama, meko kya hua hai? Now she is fine. She is asking me, Mama, what happened with me? Why this is there? Why stitches are there? Daily she asks me, Mama, ye kab theek hoga? So I don't have any answer of this question because I even don't know ye kab theek hoga. So, but I'm very happy that my daughter is saved. She was in safe hands. Thank you so much. Thank you. The medical treatment given by the AIMS it was superb. Thank you so much. We were like, we have heard about the government hospitals that it is very dirty over there. It is not easy to get the appointment. It is not easy to get the medical treatment. But actually, it was wonderful. We have visited in the private hospitals also. In Ludhiana, my daughter was admitted for 12 days. In Escort also, she was there for 12 to 13 days. But we got treated in AIMS, and it was not like we have paid the expenses there in DMC also, in Escort also. But in AIMS, it was a government hospital, but we don't have a feeling of government hospital. The doctors were on round on time to time. All the doctors were coming, and it was a wonderful experience. Like I was no, we will not shift to AIMS because we have heard of that there is so much crowd over there, and so I was not even ready. But thank God we shifted her in AIMS, and we got the treatment, and like we got my daughter well. Thank you so much, Dr. Rajshekhar. I am so thankful to you. Thank you so much. So this was all my experience which I have faced during that time. Thank you so much, everyone. Thank you.
Thank you so much, Dea. We know what you have gone through. And doctors, as you say, I mean, they are like God. We give our little babies to them and they return and the baby is well and fine. I mean, God comes in different shapes. Some have got this name, Dr. Rajshekhar. Some have this name, Smita ma'am. Some have this name, Krishna Kumar. Some have this name, Mahesh Doctor. I mean, they're all there. We cannot just count the names. They are there for our kids and for us. Thank you so much for sharing the story. And now it's time for the question and answer hour. And thank you so much, Dr. Mahesh. Sir has been waiting for such a long time. Thank you so much. Let me just give you a very brief introduction. Dr. Mahesh Kapanail, Professor Pediatric Cardiology, Amrita Hospital, Kochi. He is also the head of AIMS 3D Printing, AR and VR Lab. And he is our doctor buddy. He's been a source of inspiration right from the beginning when we started this project of Justice for Heart Warriors. And all the questions I've already sent to you. So now it is the ball is in your court. Let's play it on. Yes, sir.
Thank you, Sajni. Again, I hope I'm audible.
Yes, sir, you are audible.
Okay. So, Sajni, first of all, congratulations to you and the entire team for putting together this session. This has been absolutely amazing. I mean, even for all of us, I think this is some of the best, most valuable time that we've been able to spend with the group of all of you out here. And this is a great endeavor, and we need a lot more of this interface between the physicians and the patient families. Often, we participate in so many medical conferences where it's groups of doctors discussing about, various diseases, treatment modalities, etc., etc. But what is always missing in those conferences is the perspective of the people who are receiving the care at the end of the day. And that's been something that we've been trying to advocate also, that most of our medical conferences should definitely have a segment where we get to actually listen your side of the story. And that's been a missing link for all of us, like forever. And this is an absolutely fantastic opportunity, not only for you all to interact with physicians, but also for us physicians to hear from you. The stories that were told by Amod and Tarana and Srishti and Rajdeep, they've been like, absolutely eye-opening and soul-opening. And It's some of you like Hari, Sajni, Apu, I do know your stories personally to some extent, but then, you know, you really get to realize how different and yet same the stories can be across people and subgroups. There have been a few common themes that we've heard during this session. One of them has been this angst as to why me, why with my child. And second, there has been this angst about, you know, how come despite all the care that you took with your antenatal scans, still the diagnosis of congenital heart disease was missed. I think that has been a recurring common theme, isn't it? That, you know, you did your best, you went to you did your scans on time, and still how come this was missed? So one of the major reasons for that is that, you know, the fetal echo is a very specialized test that requires a very highly skilled imaging personnel. It also requires a specific kind of, you know, machinery and technologies also, because even the scanners come in various grades and there are various types of scanners, etc. The routine antenatal scans or the anomaly scan is usually not done by cardiologists or people who are specially trained in fetal echo. They're trained by ultrasonologists, radiologists, and often gynecologists and obstetricians. And though they are trained to look for anomalies in general, but analyzing the human heart in a fetus can be incredibly difficult, even for us with, you know, decades of experience in pediatric cardiology also. Sometimes it can be very tough, because you can imagine your heart is like the size of your fist. And now you imagine the size of the fetus that is growing inside it. So, you know, with 14, 15, 16 weeks, it's really, really tiny. And then the blood vessels coming from them are even tinier. So it is incredibly difficult and does require some training, some equipment, and a kind of a structured approach to it. That's what comprises fetal echo. It's often not possible to ensure that level of quality across the general antenatal scans that happen. And that's one of the reasons why this can be missed. Second is also that in an expert hands also, sometimes the fetus is, you know, very mobile. Fetus is moving inside the mother's womb, and you are trying to see the fetus through the mother's tummy and through the uterus down into the baby's chest and the heart. And even in expert hands, sometimes it's quite tough to identify the heart diseases. But yes, in most cases, if a fetal echo per se, fetal echocardiogram is a specialized test, it's different from the antenatal routine anomaly scans. But if fetal echo is done on time, it can identify and recognize most of the congenital heart disease well in time for you to take major decisions regarding future care. Now, fetal echo is not recommended for everybody because, like you yourself said, pediatric cardiologists, pediatric cardiac surgeons are few in number across the country. Similarly, people with the kind of expertise to do a comprehensive, very accurate fetal echo are also fewer in number across the country. So every woman, every pregnant woman may not have the, you know, access to get a fetal echo scan done. But wherever the anomaly scan raises a suspicion that there may be something amiss, usually patients are referred onwards for the fetal scan. And if it is not suspected at that level, that may not happen. Second situation where fetal echo does happen is where there is a suspicion of genetic abnormalities, or there has been another child who's had a CHD, or if the parent himself or herself has had a CHD, then there is an increased indication for doing a fetal echoes very specifically. So these are situations where fetal echoes are done, and in most cases we can pick up these kind of critical heart diseases. I know that this does not really solve the angst that is there for each of you personally, that in your personal case this was missed, but we hope that things will improve in the future. For example, in Kerala, my colleague Dr. Balu, who is a fetal echo expert, has really been fighting for this. He's involved himself with the government of Kerala, and there has been a campaign to actually train the people who do these routine antenatal scans, which are the gynecologists, obstetricians, and radiologists, in how to identify heart disease accurately. So we have created a kind of a structure, and there have been several training programs to really encourage them to look at the heart in a way that these diseases are not missed. Hopefully, in the times to come, This kind of endeavors would be taken, nationwide and even globally, so that more and more people who are involved in routine antenatal scanning will become better and better at picking up heart disease very early in the pregnancy, so that the families are better prepared and they know what to expect and can take action in advance. So this is the first concern that I wanted to address right at the first go. And Sajni, I think we can make this relatively informal. We can have some questions coming and going, and as and when necessary, I can refer some questions onwards to my other colleagues present here, Smita, Dr. Navneeta, etc. also.
Okay, sure, doctor. I mean, I'll just ask the questions, and I hope you people can decide like which question to choose and ask. I mean, select and answer. Right. So the first one is like a CHD, the issues, the future, the physiological, the psychological, and general conditions. In conditions, the child should be ready for pre and post procedures, evasive or non-evasive. What are the issues he might face as he grows to an adult? Yeah.
Like some of the sessions have already talked about the CHD. When we talk about it, it's not like one disease as we've talked about it. It's a whole spectrum of various kinds of heart diseases. And so the way the disease would progress or the treatments offered or what happens in the future depends a lot on the specific type of congenital heart disease that you or your child has. So it's very important that when congenital heart disease is diagnosed right at the outset, it's important to have a very good deep conversation with the doctors to really understand what the heart disease is about, what are the implications. There are diseases which are correctable. That is, you can completely fix them through either open heart surgery or sometimes even by just transcatheter procedures like device closures, etc., etc. And then for the rest of your life, you're actually fixed and there are going to be no major issues. Even then, we do keep a certain level of surveillance. There is a follow-up. There is a structured kind of a follow-up, so that you're always, there is always a view on how you're doing in the future, and there's documentation that you're doing well. But other than that, many of these diseases can be completely cured. Examples would be, having a PDA or an atrial septal defect or a ventricular septal defect, etc. If repaired in time, it is practically a fix for life. Even many complex heart diseases can be completely repaired, even the newborn period. So not every heart disease has to have a very complex long-term problems. Many of them can be fixed, but even then, it's very important to stay in connect with your treating physicians lifelong, so that all the problems that come up if they come up in the future, can be identified early and addressed. And the complex heart diseases like this, where you need stage surgeries, etc., there are specific problems that we address as the time goes by. Broadly, we call them as, like you've talked about, single ventricle and biventricular hearts. So what we mean by biventricular hearts is that when you fix them, you have the shape of the heart is practically like what a normal person has, right? So you have one side of the heart that is to pump impure blood, the other side of the heart is to pump pure blood. So the heart, once repaired, is working like a normal heart. Single ventricle, or the Fontan pathway, as we say, so that is where the heart cannot be converted into a state where there are two different parts. So what we do through the Fontan surgery is we let the heart do the work of the left heart, which is to pump pure blood into the body. So we do this in a staged way, so that the other half, the work of the other half of the heart, which is to pump impure blood into the lungs, that is substituted by creating this new circuit, or the Fontan circuit, where the impure blood actually bypasses the heart, goes directly to the lungs, gets the oxygen and comes into the heart. Because in most of these cases, you only have one ventricle instead of two. So we give it the work of pumping blood into the body. Okay, so this is what is the Fontan circulation. So this Fontan circulation has its the advantages that yes, now you have a functioning heart, it is working very well, your oxygen levels are nearly normal as anybody else. The limitations are that yes, there is lower stamina, You cannot do very strenuous activities. There are certain lifestyle limitations, and there are a set of things that one needs to take care of in the future. Okay, and so those are things that we need to understand from individual to individual and heart disease to heart disease, and in conjunction with your physicians, carefully understand and then follow through with these actions.
Thank you so much, Doctor. And actually that gives the answer to the second question, which was actually Fontan versus non-Fontan CHD warriors, challenges and chances. So that answer also, I mean, that question also stands answered. So we'll just go to the next one, which is about like, why do ultrasound scanning during pregnancy? So that is also covered. Yeah, what is contradict? Yeah, this is a question, like, I don't know if it is right to say, but why is it that contradictory treatment plans are suggested by doctors? What kind of action logically is to be taken by parents when faced with this dilemma? Because the problem would be one, but even in the same hospital, two sets of doctors would say, give the parents two different advices. So how does a parent actually, because parents are laymen, they don't know the technicalities of it, how do they decide as to what to go with?
I can totally understand the confusion that a parent would face when, faced with, two divergent opinions on the same heart disease. So the reason why this happens is that for simple heart diseases, there will be no confusion like that. I assure you of that. If it is simple BST, AST, PD, anything falling in the simple spectrum of heart disease, there will be no confusion anywhere in the world. The answer would be very simple and the procedure suggested would be common across the board. Where there is a divergence of opinion is where the heart disease is more complicated. And there are possible multiple ways to find a solution or to reach a solution. Okay. So in these situations, there are multiple factors that come in. Age of the child, the precise nature of the complexity of the heart, the technical difficulties in addressing that heart problem, whether to fix it completely, or whether it is too difficult to fix completely into a biventricular heart, therefore to choose the pathway of the Fontan circulation, which is technically simple, but has more long-term, things to look out for. Costs of the surgeries, the socio-economic situation of the family itself. So all these factors, as physicians, when we look at our patients, we are not just looking at that one report. We are trying to see what solution we can offer to this child for now and for the long term. So this is where the dilemmas come in. And often it is not just a technical dilemma, it is often a moral dilemma also for us. So, and so therefore, like in our own institution, we have a system that, every Saturday, the whole team of doctors gets together in what we call as the joint cardiac meeting, where the surgeons, the cardiologists, the anesthesiologists, everybody sits together as a group. And the intent of this particular meeting is that whatever cases we have seen through the week and who are pending critical decisions, we put up all this information for a discussion in the group, where all the pros and cons of each patient's case, what is the disease, what are the possible solutions, in this particular case, which would be the best solution. And believe me, there would be differing opinions, even in our own group. One cardiologist would think that, no, we should go all out and do a very complicated surgery and try to fix this. The other may say, no, this kind of an approach is too risky and it may not give benefits in the long term. So we should perhaps choose the easier option of going down another pathway. A third person may say that, no, we should not even try to intervene here, because even if we do a surgery, it may not really improve the quality of life in the future. So these differences of opinion are quite normal, and it happened in our own group also. And therefore, we try to bring in an additional check by having these kind of meetings where we discuss, and then we actually document that the discussion happened, all these factors were discussed, and we have come to a final decision that this is what we're going to offer to the patient or the family. The decision is a collective one, and it is based on our best judgment. So to cut the long story short, it is possible to have very different opinions on the same heart disease, but this usually happens in the more complex category of heart disease. And I can understand the family being confused about this thing. What they should do is have a very clear, open discussion with the treating physicians as to what is this decision about, What are the alternative options? Why is this option being chosen for me specifically? So those things, if you understand better, then you would be better aware of what's happening. And there's absolutely no harm in taking a second opinion, asking other experts in the field. When we take a second opinion, it's important that seek out people through various networks who would be people who would be able to give you an expert opinion or a knowledgeable opinion. Because not everybody, not even doctors, not everybody would be aware about the complexities of the decision making in these cases.
Okay, thank you so much, Doctor. I hope I'll just move on to the next question. And the next one is, when a child or adult is detected with CHD, is a patient liable to all the information, including risks and future complications and consequences of not following up? If so, are they educated by the hospitals? There is another thing to it. At times what happens is one particular problem regarding the heart is corrected, but then some other organ starts getting trouble. Right. So even I was asked to choose between the heart and the kidney. So I said I want both, and I left from the hospital. So I mean I don't want to sound like this, but this is actually what happened. So treating a particular organ compromise another organ. Is there any way where this doesn't happen?
Sajni, to answer your primary question, absolutely, you have the absolute full right to know everything about the disease or whatever pathology is diagnosed. Absolute full right. And it is your right to speak to your treating physicians as many times as you need or as you want. And it is the duty, our duty as the physicians, to explain things to you in the greatest possible detail. And if we do not do that, it is our failing if we are unable to really explain things to you. Sometimes, in the real world, it is possible that physicians may think that a family is unable to really understand the complexity, so they may try to put it in simple words or really dumb down the whole issue and try to explain it away. But that said, you at the receiving end have every right to sit down and demand to know more and get full clarity on it. And that I think is very important also, because many a times when heart disease is diagnosed, one is in a very, very dazed state of mind. And one finds it very difficult to accept what has just happened and being given a diagnosis of heart disease. And it's difficult to really think through it. And sometimes even when we are speaking to the patient, we can see that they are completely off, because you're thinking of so many things at that time and you're not even listening or able to understand what the doctor is saying. In such situations, it's always wise to go back, have a cooling down period, and then think about it deeper, and necessary come back, speak to the doctors, understand in detail what exactly it is. What are we talking about? What are the options ahead of us? Why? What is the advantage, disadvantage of each of these options? And it's very, very important that you exercise that right. That will also make us as physicians more confident in treating your heart disease.
Okay, thank you so much, Doctor. Moving on to the next question. Why is there no social security system or health insurance for the adult CHDs? I guess this question has been already taken by Smita ma'am, so I'll just move on to the next one. Is there any specific lifestyle a CHD child or adult needs to follow to increase the lifespan and prevent infections?
Again, I think Dr. Navneeta also covered part of it, that, and Smita also, that, not every heart disease is the same. There are very specific recommendations depending upon case to case and disease to disease. And there are no blanket recommendations in general. Even for people who've had a certain kind of heart surgery also, depending upon that person's fitness and overall environment, nutrition, I would advise that person specifically with regard. And there are different people with different interests also. There are, not everybody, not even me, I'm not an athlete. And it's not as if, every person with CHD is trying to be an athlete also, right? But there are people who have certain interests where we are able to guide them properly. Okay, you can do certain things. These are the set of precautions you need to follow. Again, I think communication is super important. Broad guidelines may not work because of the very specific nature of congenital heart disease. But yes, if you communicate with your treating team, you can really figure out what kind of lifestyle modifications to take. And of course, other than that, the general healthcare advice, general lifestyle advice, I think it's because one already has an issue with the cardiovascular system, it makes sense to follow a general lifestyle that is cardiovascular friendly, right? Be it in terms of diet, be it in terms of exercise, rest, sleep, etc., etc. Those do go as common guidelines.
Do we have any like manual or any handbook or something that CHD association or something can provide regarding this? Like,
not that I'm aware of that there would be a manual on this, but I think you know, again, like as per individual heart disease, please get in touch with the physicians to really understand what is the physiology, what is the heart disease. Have you been totally fixed? For example, if it's in VST who's been completely fixed, he could do anything. He can be even an athlete, right? So, so depending upon that, there are kids who have had heart surgery, who've gone to do they finish their PhDs, who are doing brilliant in their career, who are, you know, brilliant artists, where, you know, they're able to do everything that their passion is calling for, right? So it's just important to understand.
May I intervene?
Yes, Smita, please.
Hi.
Yes,
Mahesh, so many CHD, like they one thing, which is even for the simpler heart disease post-intervention or even pre-intervention, where we say that there is no need to go for any intervention. After a while, 10, 12 years of age, a simple TMT can be very indicative that of your functional capacity. So it can be done. And we keep on doing it for the valvular heart disease and all, where we are letting go a person for the pregnancy or anything. So the simple functional evaluation is important. We can do that.
Absolutely.
Thank you so much, ma'am. And let me just move on to because we've got like 15 minutes time. Like I'll just rush to the next question. In the situation when faced with an emergency, what is the first aid a caretaker can give, and is there any common emergency number where help could be available, as a hospital would be too far for the child to reach in time? What to do in such a scenario?
That's a tricky question because again, it depends upon the type of heart disease one has. For example, if somebody has had a BT shunt or a PDA stent, those babies are at risk of, you know, a blood clot really compromising the flow into the lungs, and suddenly, you know, a baby could turn very blue. There could be a baby with TOF or tetralogy of Fallot, where one could have something called a cyanotic spell, where again the oxygen levels suddenly fall and baby becomes very blue. And of course, as a first aid, there are a certain set of actions we do tell the mothers. You know, if a baby has a TOF and is having something called a cyanotic spell, we do tell the mother to, you know, immediately hold the baby in a position that the knees are folded against the chest, try to calm down the baby, but at the same time try to seek medical attention as soon as possible at the nearest center possible. And the families who have a risk of facing these situations should, you know, try to have the number of the nearest medical center that they can go for help in case something like this happens, and be aware of where such help can be sought. Now, Nita, do you want to add to this anywhere?
Yeah.
I mean, unfortunately, you know, we still do not have an organized system like, you know, which would like cover across hospitals or like systems. But I'm sure that like each treating hospital will have a way of dealing with emergencies. Like in Amrita, like whenever we discharge patients, according to their needs, we would be telling them what all are the specific things that they have to like watch for, and what are the danger signs especially. So as has already been mentioned, like in tetralogy or fallow, like, spells are something which, we would want the parents to watch out for. Like if it is a situation where the baby can go into heart failure, then we will be telling them, like, what are the things to watch out for. And, so this thing, the danger signs vary from physiology to physiology. And accordingly, what we can do in each setting will also be different. And what I would tell is, like, it's important that you, whenever you go to any particular healthcare facility, you should understand what is the way to contact them in case of an emergency. Like, is there a phone number where we can, that is how we are handling it. There is a number where, our patients can call and talk directly to a doctor if needed. So, so I'm sure that every healthcare facility will have a system like that. And that is currently what we have actually. And it is important you understand about the disease yourself so that you will know what to watch out for, so that if a situation arises, you will be able to deal with it. Sometimes I even tell parents that, like, you can go to the nearest healthcare facility and tell that your baby has this particular heart disease and this particular procedure has been done. And if this happens, we have been told to look for this. So, we can empower parents to that level. So even if they can't reach the tertiary care center in one go, even the nearest hospital where even an adult cardiologist is available, if they can be primed about like what to look for, they'll be able to help in an emergency. So these are some of the ways where we can overcome some of the deficiencies in our, like, healthcare system, where we don't have an EMS number to call like in the Western societies.
Absolutely, Navneeta, well spoken. So I would also appeal to, people like Hari and others with the creative ability to maybe probably even think of creating systems where there is an emergency number, which are, driven by the location and the available facilities around, so that, it could be an app, it could be a database where it's easy for a parent to quickly seek help from where they can get some basic expertise.
Yeah, thank you so much, Doctor. I mean, the need for a common database and a common number, it's like really, really important, because that is one thing that we all look forward to, because our kids, when they grow up, they go to different towns, different places, and we really do not know how safe they are. If there is an emergency number, yeah, it would be so good. And if the name is saved in the database, even if they meet with an accident or something, immediate care would be given, or else not knowing that they have a heart condition, if something is done, it's like risking their life. So
I'm sure we can create something like that in the times to come, because technology will allow us to do things like that. So yes. I think in the times to come, we would be able to create systems like that, where it's easy to access help and get precise help.
Yeah, thank you so much, Doctor. Moving on to the next question. Yeah, that was actually about networking itself, networking of hospitals. Now, is it possible that each and every, in government hospitals and all, when we have gone, it's like every time we meet a different doctor. Private hospitals, we get a doctor, but then the procedure is so expensive. So if there is an umbrella system wherein all the doctors can be connected, all the hospitals are connected together, and basically the health of the student, I mean, of the children, that's most important. So if a system is like that, wherein even if a patient is registered in a hospital and they can avail the treatment at a lower cost, or from a different hospital, depending upon the economic status or the severeness of this condition, which particular hospital would be good. Is there any kind of networking that is possible that way?
I think again, this should be something for the future, where we create more, more flexible, more a network of institutions, hospitals, which are able to provide the care and have the patient the ability to get information about them and being able to access them. I think these are system improvements that need to come in, rather than each one working in a silo.
Yeah,
multiple institutions working in a silo, and this is a real problem, what you're saying, that you don't have continuity with the physician that you're seeing. You find it difficult to travel all the way to another hospital, etc., etc. Of course, we have to understand that not every institution and every team would have the same level of expertise. Also, there are centers which have very high level of expertise, who are able to manage really, really complex problems, whereas a lot of other institutions would be able to handle simple problems, but would not have the wherewithal to handle extremely complex problems. So again, there is a difference. So there will be that difference in the level of expertise, infrastructure, etc. across institutions. But at the same time, I think, yes, there should be better systems where there should be better communication between institutions and more willingness to actually work together towards the common good.
Right, right, doctor. That's really the need of the hour. We are going through 5G and so much of technological advancements are happening. So at the hospitals, it would be so nice for the parents and the kids, and generally the medical care needs an upgrade. Everyone has to have, not just the congenital heart defect people, everyone has to have a medical card wherein all the details regarding their health could be there, and they could avail a medical facility anytime, just the press of a like a button. That is the ideal kind of a thing. Yeah. Yes. So the next question is about, this is like a question which came to my mind so many times, like some test is not, like an echo is done in a hospital, and we have to take the kid to another hospital immediately. Maybe it is just a week apart, and again we're asked to do the same thing. What is the validity time of this, or is it like mandatory that every hospital, all the tests has to be repeated when already you have got tested and you're carrying the report? Why does this happen?
Right. So, take for example something like a blood test report. You got your blood test done from a lab. So the lab gives out a set of readings, and they're pretty standard, and they can be interpreted by anybody who sees that report. Even an X-ray or an ECG can be something like that. It's been taken, and for that moment you have the record of what was found on that. But some of the tests like echocardiograms and angiograms are very, very operator dependent. And they depend upon the knowledge, the skill, and the way the echo was done by that particular operator. Okay, that's the main difference between, say, an adult cardiologist doing an echo for a child with CHD versus a pediatric cardiologist doing. Both are cardiologists, but the adult cardiologist has been trained in a different way to look for a different set of things. So even though they may be able to look at a pediatric echo, but they do not go through the kind of rigor that a pediatric cardiologist goes through, because there are, like, heart is made up of various different segments. So we ourselves go through a lot of training to go through that checklist to accurately identify all the problems. And again, the echo is a very operator dependent issue, where how you keep the probe, where on the patient chest, what are you looking at, how do you angulate it, the images that you get can be very different. And so is the interpretation of those images. So which is why echocardiograms often are repeated by the experts, because that judgment has to come from within them, because they're going to take the next stage decision about whether this patient needs a surgery or not, or what kind of care is going to happen to that. So it's extremely difficult to go by an existing report which is already there. You need to see again, before taking these important, crucial, life-saving decisions, you need to really understand the internal anatomy, the functioning of the heart, how the blood is flowing, whether an intervention is needed, how soon is the intervention needed, what will happen in the future, etc. And it has to come with a very individual perspective. So that is the reason why this echoes are often repeated, and that's really, really necessary to come to a good decision. Similarly with angiography also. It depends upon how the operating team conducts that angiogram, the kind of information that you get. And many a times, these are dynamic information. They keep changing with time also. Suppose an echo has been done a month back, or an angiogram has been done, say, 6 months back. Some of the information that was got at that particular time may not be the same right now, because the body, the heart, everything is adapting and changing in response to the heart disease, right? So therefore, it's from the patient perspective and from our own decision-making perspective, it's very, very important sometimes to look at it again in a large number of cases. That's the reason why we often ask them, okay, oh no, we need to repeat the echo again. It's not like the simple blood test or an X-ray film, which you can just see and interpret.
Okay, next time we take an echo, you'd be feeling like, okay, this is fair.
No, it's very important, because that really goes into, because an echo is, you do a lot of intellectualization when you're doing the echo. You're trying to understand what's going on with this heart. What is this? What is happening to the heart? What is happening to the baby? What do you need to rectify that? And as treating physicians, it becomes our utmost responsibility that the decisions that we take should be really accurate, and we own the responsibility for it.
Yeah, perfect. Yeah, that is owning the responsibility. Matlab, if echo is done based on that, you would be like doing all the procedures. So it is very important that it has to be done at that particular hospital. Yeah, that is right. And now the next one is like, this is something which I don't know how to put it across, but basically, how do we do this? How do we push the agenda for more hospital, better infrastructure, better conditions for doctors and pediatric cardiology, more doctors, balanced job hours for the doctors, better pay packets and perks, upgraded government hospital, inclusion in health insurance policy making. Matlab, the whole thing is included in this question. But I mean, what is the reason that the government is shutting the eyes or ignoring, in spite of the huge picture of the fact that 1 in every 100, one child born out of every 100 has got this particular thing, and adult, not much of a research is done in adult congenital case. What can we people do to push this agenda? How can we make the government to just open their eyes and address this, at least have a common platform where we can talk with them and tell them, okay, these are the problems, what are you people, what can we do about it? Not just them, all of us, what can be done regarding this? So that's another question.
I think you've made the right start in this, because we need your support in doing this. The voice has to come from you, that the need that, that has to be felt by the governments, because the government has so many other priorities, right? So until and unless we, really advocate for the needs, it is often not heard. The governments, both at the state and the central levels, have to really understand the priority of, of congenital heart care. And while physicians and teams of doctors can keep on advocating for that, but I think the strongest voice comes from you, where the patients who need this, they have to come forward. Often what happens is that, care, one goes to the hospital, gets the care, goes back. Now look at all of you. You are actually collecting together for a cause that is greater than your own, right? You're not just talking about treatment of your own child or yourself. You're talking about trying to improve systems, trying to advocate for improvement from the government. That is the critical need. That's a real important need, and that's what really makes governments also wake up and policymakers really become aware. And of course, like Dr. Smita has very clearly outlined about how she struggled, push certain, policy statements forwards, to get insurance coverage, etc. It is challenging. Of course, the red tape is there, the bureaucracy is there, the government setup is there. It's difficult to push things through, but at the same time, I think collectively we will be able to make enough noise to be heard. Dr. Smita, you want to add to that?
Yes, Mahesh. Hello.
Smita, can you add to this particular
Mahesh,
question on how to make?
I am like a little, maybe seem like dreamer, but in 2016 I made an idea about the bringing a health television with all social media attached, with all group of the doctors over there, and to ready to do 1 hour OPD every day, and the partnership with the various conferences, and of course the the medical condition based, the serial and all. So I made everything, but the problem was you need around say 20 crore rupees as a first investment, which I was not able to collect. So still I think that one day we will be able to do a YouTube channel based health program, where we actually give proper OPDs also, and we make use of social media. And like everybody is having smartphone, like a baby is sick in a very remote area, somebody can show us, send a video, and we can know that it may be a spell, cyanotic spell, and we can we can provide the basic instruction to local person, whoever is medical person, so they can take care of that baby. And then we should have a ambulance, and also we can provide
So again, we focus on
the ambulances also, and we can find out which hospital will be nearest.
Yeah. So again, I mean,
So
basically
that
networking,
kind of
advocacy, using technology appropriately, we've been
technology and
able to find.
smartphones are such a big technology, you know. We have started a child literacy group also in Delhi. So we are just making the around say 20-30 students from the every school. They have been given certain kind of pulse oximeter and all those things, and they have to take the pictures, and they have to connect with their elders in family, their teachers, or maybe the local health facility. So this is what we have started doing.
Sunil sir, you want to say something upon
Yeah,
this?
I just want to say regarding inclusion in the insurance schemes. See, there are companies which provide insurance schemes, so like a person working in ONGC, and some of the good IT firms like TCS, Infosys, they all come with the insurance schemes which provide surgery, pre-surgery for CHD. Somehow our local insurance, Star Insurance, and I don't know what it is. What we need to find out is how this insurance, these companies, this CHD become viable for them. And is there any high premium for that? So that part we discuss with the companies that don't provide, because majority of the insurance in India is done by, I don't remember the other names. So that is why I'm telling Star and other names. So why they are, it is unfeasible for them. Why it is feasible for certain companies?
Hello.
Yeah, ma'am.
Hello. Like ICIC Lombard started a family coverage for the JNK, and there all the kids, all the babies were covered under that. All the population was covered, but then because it was a government thing, so it was very lucrative for the agency. But once the payment part came, then there was a lot of corruption. So they have to withdraw that scheme. So that is the biggest culprit, that corruption part, because unless, as I said, unless government takes the insurance coverage instead of direct financing, things will not move. So that is the most important part.
Yeah, I totally agree with that, because until and unless policy making, like a changes, a major change is done over there, funding is a major issue. Like all the survey forms we got, basic thing was having a congenital heart defect person with us. It is like having a huge financial burden, and that's a fact that we have to accept. And then without any kind of a health insurance policy or social security scheme, it becomes so difficult. And I'm very thankful to the people who are running NGOs and all, but it feels really sad to see pictures of parents and kids sitting and crying. And I mean, if this is, the government has banned begging. If this is not begging, then what is? I mean, it's not fair. You ban begging on one line and you allow it on another, saying that, okay, it provides for the surgery of a child. I mean, the government has to find an alternative way wherein a common funding is there. I mean, so many film stars and all are there. They are there to be the faces of big brands. Why can't be the brand ambassador of CHD cause? Why can't they just come forward and do some programs? We'll collect the fund. We'll have a common funding, which would straight up go to the surgeries instead of the parents having to wait in the queue or put in pictures of crying babies, and that it's inhuman, I would say. So it's high time that the government actually recognizes what's happening and not to take double standards here.
So we need strong advocacy. Again, Sajni, I mean, I think this is a great start. All of you need to, really muscle up and muscle your way through. We need really strong advocacy.
Mahesh, I will again insist that because first trimester, there is no diagnostic tool to say that there is a congenital heart disease or not. So that is the time when a policy can be started.
That's a great
so
idea.
That
Actually,
will be very lucrative for the even insurance agencies, because because there was a cradle care policy which was started by the Oriental insurance company, and they were like asking for 1,500 rupees per pregnancy, and they were giving 2.5 to 3 lakhs capping amount. But what happened? They never popularized it, and they actually withdrew it in 2014. So these kind of policies can only act once you are giving them when you cannot make a diagnosis. Like first 3 months, when diagnosis cannot be made, when there is a chance, there is incidence rate is less than 1%, when there is a chance of anomaly scan and the abortion. So that is also a good possibility. So I think that is the best possible way for the insurance. We have to aim at the first trimester insurance, health insurance.
Exactly. Yeah. Together, I hope we'll be able to make some change, and like we'll push the as far as possible. If I guess all the people, everyone, all the CHD, the total CHD community, the doctors, the parents, the adults, if we stand together, I mean, it is a thing that has to be addressed. So something might happen in future. I don't know, but still. And here are some very technical questions that has come up, like. Do some medicines cause problems in heart rhythm? Yeah, that is one question that has come up. Do some medicines cause problems in the heart rhythm? Is it possible, like some medicines might cause this?
Navneeta, would you like to take the question?
Yeah, pardon me. Can you please repeat it once more? Like
There
medicines
was a
causing?
question. There was a question from the patient subgroup asking
I'll
what
repeat the
medicines.
question. Do some medicines cause problems in heart rhythm?
Okay. Okay, so that's a very good and very relevant question, I would say. So we can look at it from 2-3 different points of view. One is, even in general population, there are some medicines, quite unrelated medicines, which even when given to normal population can cause changes in the heartbeat. That is one thing. Second is, if we look at congenital heart disease population, some of them might already be on some medications, and there might be other medicines which can interact with these medicines and then cause heart rhythm abnormalities. And the third, I would say, aspect is, if some congenital heart disease patients are on some particular medications, certain changes that happen in the body can push them to have some, rhythm or heartbeat abnormalities. Like, if a patient is taking a diuretic like furosemide, which we call Lasix, and if they simultaneously develop like vomiting or diarrhea or anything, there will be more loss of what we call electrolytes from the body. And like potassium, you lose more potassium, and then that can lead to heart rhythm abnormality. So even without a disease, you're already on one medicine, and some change in your body can cause heart rhythm abnormality. That is one. Two is, suppose you are on some medicine like, again, like, because furosemide is one of the commonest medicines, so I would go with it. You're on Lasix and you had a fever or an infection, and you were given some antibiotic, which also has some ability to change some particular things on your ECG or the rhythm of your heart. And then, in the background of already taking Lasix, or some children are on digoxin. So in the background of Lasix and digoxin, there could be even some antibiotics which can, like, cause changes in heartbeat and push you into problems. So whenever you are on medications, already cardiac medications, and you're taking another medication, it is important to tell the prescribing doctor that you are already on these medications. And another point is, like, some heart diseases, some children with heart diseases have some residual abnormalities which can predispose them to heartbeat abnormalities, like even repaired tetralogy of fallow patients who have some, most you will be aware, if you have tetralogy, that even if after repair, a subset of patients can have like valve leaks and a little bit of dilatation or enlargement of the right side of the heart. And some of these patients, like if you have 100 such patients, 1 or 2 might anyway be at risk of a heart rhythm abnormality. So with that underlying heart abnormality, you're taking a medicine which can precipitate a heartbeat abnormality that can push them into such sort of an issue. So there are certain medications like that, and most of the doctors are aware about it. You would have, at least some of you would have listened to it during the pandemic time, and there was a lot of discussion on chloroquine and the heart abnormalities that it can cause, azithromycin, another antibiotic, which can cause heartbeat abnormalities. So there are drugs out like that. It is important that you mention to any healthcare provider what your underlying issue is and what medicines you are on whenever anybody is prescribing a new medicine for you. So that can help avoid a lot of such problems. I hope it clarifies a little bit.
Yes, ma'am.
Absolutely.
Yes. Yeah, absolutely. Like since we have like taken your lunchtime as well, I'm sure most of the doctors will be hungry here, so sorry about that. But it has been a really useful session, and we have a few more questions, but I'm sure I'll just ask this in person, because I mean, you people are all nobodies now. We can always get to you, no worries. So on that note, we are going to ask one of our friends to do the vote of thanks, and at the end we'll have Tarana. She wants to add something. I mean, she really wants to say something to all of us. So may I ask our heart mom to please give the vote of thanks here. Thank you so much, Mahesh. Doctor, you are like the driving force of our Justice for Heart Warriors. Totally cool. Yes. Yes.
Yeah.
Yeah. Yeah. Are you there, Risma? Yeah. Chalo, yeah. Let's do it.
Good afternoon, everyone. Someone said, feeling gratitude and not expressing it is like wrapping a present and not giving it. So today, I take this opportunity to put all my gratitude in the form of words. In fact, it's a great honor to propose the vote of thanks to all who have helped us in making this webinar such a resounding success. Respected and our most distinguished mentors, Dr. Sunil J.S. sir, Dr. Mahesh Kappanil sir, Dr. P. Rajasekhar sir, and Dr. Anita Saxena ma'am, though ma'am is not here. First of all, I would like to express hearty vote of thanks for gracing today's webinar and for your support and guidance throughout. Also, thank you, Mahesh sir, for enlightening us with the answers to our questions. Distinguished speakers, Dr. Maniram sir, Dr. Navanita ma'am, Dr. Sri Hari sir, and Dr. Smita ma'am. Sri Hari sir, I think, I'm not sure.
Yeah, he couldn't join the meeting, yes.
So I'd like to propose our profound gratitude for your wonderful and thought-provoking talks. We, the CHD parents and CHD adults, desperately need to be heard. Dear Ms. Tarana, Mr. Amod, Mr. Rajdeep, and Ms. Srishti, you were the voices of our CHD community today. I request you for to accept my vote of thanks. I express my sincere thanks to Dr. Krishna Kumar sir and Veera Lakshmi ma'am from Children's Heartlink, and also Mr. Heru from Little Hearts Indonesia for joining us today. I'd like to thank all the respected doctors who have spared their valuable time in responding to our queries through the questionnaire. Thank you all from the bottom of my heart.
Thank you so much, ma'am.
I'd like to deliver vote of thanks to our most active and skilled members, Appujars, Hargabi Kangara, Sajni Nayar, Hari Krishnan AM, Salaka Parab, and Sindhu Lakshmi for their continuous engagement technically and otherwise too, to make this dream project a reality. And thanks to Mangala Ganesha ma'am too for helping us. Finally, I would like to thank all the adult CHDers and CHD parents and caregivers who have participated in filling our questionnaire and also in today's webinar. Once again, I express my vote of thanks to one and all present here. Thank you so much. Thank you.
Thank you so much, Risma. Thank you. And before we go to Tarana, who wants to share a very special phrase, there is we need to take this. Rohit Upadhyay sir has put a question. My general question is, my kid is taking acitrom. I hope I pronounced it right. ACITROM. 1 mg per 1.25 mg alternate day, and NVAS 2.5 twice a day after Fontan in 2019. My concern is that, is there any side effects to these drugs for taking for such a long duration? And is there thing which I can do to avoid, is there anything I can do to avoid side effects? Yeah. Can anyone please answer it? Yeah.
Navneeta, again, I would request you to take the
Yeah,
question.
Navneeta ma'am, you there? Yes, yes.
Okay. I've seen that question. So, yeah, taking acetron long term, I'm sure that your doctor would definitely have advised you to monitor like INR and adjust the medication accordingly. Because we have a target INR and we would not want it to be lower or higher, because higher can cause bleeding complications, and lower INRs will not do the job that we actually want the medicine to do. So that is one thing. And when enalapril is being taken long term, at intervals, we would like to do some blood tests and make sure that it is not causing any issue. You can contact your doctor and do the blood test. The frequency of doing the blood test will depend on the patient. It will be varying from patient to patient. So you can contact your doctor and do the blood test and ensure that the medications are not causing any side effects.
I hope, yeah, that answers the question. And is there anyone who wants to ask a question? You can unmute and ask, and then we'll just take Tarana and we can just say bye to all till we meet again. And I have to extend my thanks to Edwin, Dr. Edwin. I saw him, and then before I could welcome him, he just I couldn't see him anymore. So, and KK sir also for being present and for encouraging all our endeavors. So is there any other questions? No. So Tarana, it's all yours, ma. Tarana, Itabasum.
Hi.
Yeah, your last phrase, right? For all of us, yeah.
Thanks for giving me floor again. I'm here to say some words to conclude my part. Just as I said, I'm happy for being here with you. The whole session was tremendous, full of knowledge and emotions. Thanks to each and every one of you, Dr. Sunil sir, Dr. Mahesa, Maniram sir, Samita ma'am, Dr. Navneeta ma'am, and pardon me if I've missed some names. Truly, we're honored that all of you gave us so much time. Salute to Samita ma'am for being a dreamer and working toward to achieve this. Thank you everyone for sharing their stories and concern. We, the parents, are forever grateful to the doctors, those who helped their children to have a second chance in life. I would like to name a few from my country. Please let me do this. Dr. Humaira Zahida ma'am, from diagnosing my daughter's defect, because that helped me to be prepared from the very beginning. Dr. Prakash from Narayana, because he was the one who gave me hope on the first place. And he said, God can make anything possible. Just we need to try. And yes, we tried. Dr. Sharifudjaman sir from Heart Foundation Bangladesh, his hand was praised by the other doctors while the procedure was done. And last but not the least, Dr. Sudesh Prabhu sir, who did my daughter's baby gland of Yusra. And today's session made me realize that actually CHD knows no boundaries. The pain and the struggles bring us close together, no matter where we reside. Again, I'm so happy to be here, present my story, and be a part of your cause. Though I'm from different country, but I'm feeling so much connected to all of you. And thanks everyone for make me join this. I'd like to end my speech in my native language, just 2 lines. আমরা যদি আমাদের বাচ্চার জীবনকে সুন্দর আর স্বাভাবিক করার জন্য চেষ্টা না করি, তাহলে তাদের জীবন সম্পর্কে সবার কাছ থেকে যদি ভয় বা লজ্জায় ব্যাপারগুলো আমরা চেপে যাই, বাবা মা হিসেবে আমাদের কর্তব্য পালনে তাহলে বলতে হবে আমরা অক্ষম। বাচ্চার সমস্যা সম্পর্কে বিস্তারিত সব তথ্য জানার অধিকার আমাদের আছে। জিজ্ঞেস করবেন বারবার, অধিকার আদায় করতেই হবে আপনাকে, আমাকে, আমাদের সন্তানের জন্য। As we have the right to know every details about the defect, we need to know how to exercise the right. Okay, that's all from my end. I pray our CHD warriors live to their fullest with livelihood. Greetings and bye-bye from me. Up to you, ma'am.
Okay, thank you so much, Tarana. That was really like a Tarana to our ears, right? Like so musical, so beautiful. And Bangla is one language that I really lose my heart to, right? So on that note, very happy that all of us are together, like on a single platform. The doctors whom we used to watch from their distance.
Exactly.
Oh my God, a doctor is coming, and now they're like buddies with us. And our children are safe with you. We are so confident now. So on that note, and Dr. Rajshekhar, my goodness, thank you so much. I mean, you have stayed put throughout the program, and without the conversation we had, that is what led to all these things. I'm so thankful, really. All of you, all of us. I mean, together we'll bring about a change. We are not an NGO, nothing at all. But then we are small people, and just like they say, small steps, baby steps at a time, we'll be there. On that note, thank you all for being here. God bless and keep us all safe and healthy always. Keep smiling.
Thank you, everyone. Thank you very much. All the best.
Thank you.